Medical University, Lucknow. Welcome all the distinguished people sitting here and those who have joined online to this gastropulmonary conclave, organized jointly by UP chapter and Lucknow branch API. Before commencing the session, I would like to request all of you to please rise for the traditional Saraswati Vandana. Please.
या कुंते तुषार हारितवरा या शुभ्रवस्त्रावृता या वीणावरदण्डमण्डितकरा या श्वेतपद्मासना या ब्रह्माच्युत शंकर प्रभृतिभिः देवैः सदा वन्दिता क्षमा पातु सरस्वती भगवती निशेषजाड्यापहा।
For this, I would like to invite Professor C.G. Agarwal, sir. So please come forward for the light lightning. Dr. Jeevan Prakash, sir. Dr. Atul Malhotra, sir, past chairman, Lucknow branch. Dr. Rajiv Avasti, sir, past chairman, Lucknow branch. Dr. Kausar Usman, sir, past chairman, UP chapter. Dr. K.K. Savlani, sir, past chairman, UP chapter. Dr. S.C. Chaudhary, sir, secretary, UP chapter. Dr. Nirupam Prakash, sir, secretary, Lucknow branch. And finally, our current chairman, UP chapter, Lucknow branch. Sir.
या कुंते तुषार हारितवरा या शुभ्रवस्त्रावृता या वीणावरदण्डमण्डितकरा या श्वेतपद्मासना या ब्रह्माच्युत शंकर प्रभृतिभिः देवैः सदा वन्दिता क्षमा पातु सरस्वती भगवती निशेषजाड्या।
Now I invite Dr. Nirupam Prakash, Secretary, API Lucknow branch, to formally introduce Dr. Sanjay Tandon, sir, Chairman, UP chapter, Lucknow branch of API, and request Dr. Tandon, sir, to give the inaugural welcome address. So please.
It gives me great pleasure to invite all the delegates to tonight's function. And this is first of a kind, as Dr. Ambuj rightly pointed out, that this is first of its kind presentation where we have been linking to 9 other centers. And without much ado, I invite now the chairman, the joint chairman of UP chapter as well as Lucknow chapter to the dais and give the welcome address. Dr. Sanjay Tandon, please.
Good evening, respected seniors, teachers, colleagues, and my dear friends. It is with immense pride and enthusiasm that I welcome you all to this gastro-respiratory conclave, a landmark initiative under the UP chapter of API. This marks our first ever interactive CME pilot project, seamlessly connecting multiple city branches across UP. Today, we take a significant step towards fostering collaboration, knowledge sharing, and excellence in medical practice. We are honored to have an exceptional panel of distinguished speakers. Dr. Gauradas Chaudhary sir, Dr. Deepak Talwar, they've come all the way from Delhi, alongside the young and dynamic Dr. Gaurav from PGI Lucknow and Dr. Arjun Khanna, again from Delhi. They'll provide invaluable insight into the crucial gastrointestinal and respiratory topics, enriching our understanding and enhancing patient care. Equally integral to this event is our esteemed panel of chairpersons who will ensure that the session remains interactive, thought-provoking, and clinically relevant. Their expertise and engagement are invaluable in making this program truly impactful. This initiative would not have been possible without the tireless efforts of our chapter secretary, Dr. Shyam Chaudhary, and the enthusiastic participation by each one of you. Your commitment strengthens our association and fuels our collective pursuit of medical excellence. I also extend my heartfelt appreciation to our satellite branches, which are there, their chairmen, secretaries, nodal officers, and all distinguished API members of the linked city branches. Namely, we have 9 city branches of UP, all across UP, who are linked at present. They are Kanpur, Allahabad, Agra, the newly inducted Ayodhya, Bareilly, again a newly inducted branch, Meerut, Varanasi, and Gorakhpur still in making. And of course, the host city, that is the city of Nawab, Lucknow. Their swift execution of this program, despite the short notice, exemplifies the unity, resilience, and camaraderie that defines the UP chapter of API. A special note of gratitude goes to Sun Pharma Gastro Division under the leadership of Mr. Rajiv, Manish, the NSM for their unwavering support and generous educational grant. They, along with the whole team, have been instrumental in bringing this event live. This event, in fact, is a testament to what we stand for, a strong, collaborative medical community dedicated to advancing healthcare system. Above all, today's gathering reflects the strength of API made possible by the blessings of our teachers and seniors and the steadfast support of this esteemed audience. You, in fact, are the backbone of our association, and your presence here reaffirms our shared commitment to medical progress. With this spirit of unity and growth, let us continue our journey towards empowering the future of medical science through the physicians of India, the elite gathering of India. Thank you all, and long live API.
Thank you, sir, for your speech. So as we all know, one of the most pressing challenges in respiratory medicine is chronic obstructive pulmonary disease. It remains a leading cause of morbidity and mortality worldwide, affecting millions of people and placing the immense strain on both patients and healthcare system. Despite its prevalence, COPD is often underdiagnosed in its early stages, leading to delayed intervention and worsening outcomes. In the recent years, however, there has been a paradigm shift how we understand and manage this COPD. So the first session is regarding COPD, what's new in the management of COPD. For this, to chair this session, I would like to invite Dr. K.B. Gupta, sir. Sir is presently Professor, Eraz Medical College, Lucknow. Sir is retired professor and head PGI Rohtak in Department of Respiratory Medicine. Dr. Javed Ahmed, sir. Sir is senior consultant, Vivekanand Hospital, Lucknow. Dr. Qaus Usman, sir. Sir is professor in Department of Medicine, King George's Medical University, Lucknow. Now I would like to request the chairpersons to give a formal introduction of our speaker.
Good evening, friends and respected seniors. First of all, my sincere thanks to the API UP chapter, especially Lucknow branch, just giving this opportunity to chair this very important and prestigious session. Now, topic is very, you can say, currently discussed, and it is what is new in the management of COPD. The gold guidelines has come in 2025, and they have made so many changes to deal with the diagnosis as well as the management of COPD. Now, speaker is very well-known renowned personality, Dr. Arjun Khanna. Dr. Arjun Khanna, I know very well. He is very close to my heart and a very good speaker also. And he is currently the professor and head and director of the Department of Pulmonary Medicine in the Amrita Institute, Faridabad. So I invite Dr. Arjun Khanna sir to kindly do his talk.
Thank you, sir. Thank you. Can I please have the presentation? Yes. So I thank Tandon sir and API Lucknow and UP for having me here. I'm an alumnus of KGMC. I am from the Gandhi ward, and it gives me shivers and it gives me deja vu. I am a DM examiner, but yet I see my MD teacher sitting over here, and for years, I'm nervous talking about something like COPD, which I do for a living. So I'm very, very happy that I see postgraduate students from the medicine department of KGMC over here today. And I hope of all the audience, you kids go home wiser today. I thank every one of you for having me here. I look forward to, excuses to come back to Lucknow. So here goes COPD, a management update in 2025. So why is this required? This is 2025. COPD is the commonest disease that we know of. A respiratory physician, a general physician, everyone knows about COPD. What's the big deal in COPD? It's a huge deal. It's a big, big deal. This is one of our papers which was published a couple of years back in the Indian Journal of Respiratory Care. I am MD medicine by training. And when you have a basic background training in internal medicine, the worst system that you can take care of is respiratory system. Because, I'll tell you, during our says, the concept was respiratory patient hai to KCH kata do. And I think that still would probably exist. I'm very sorry for being so candid. So I think we had long cases in neurology, we had long cases in cardiology, we had short cases in hematology. None of us ever presented a respiratory case. And that was something which was, terrible. And, as future would hold, lo and behold, I did my DM in pulmonary and critical care medicine. So I analyzed prescription of patients, who would come to me from MD medicine physicians. And this was a very interesting analysis of patients who were seen by MD medicine physicians like me. And 60 severe COPD patients, 100% deviation from the gold and Indian COPD guidelines. So we just analyzed 160 patients who had severe COPD. When we analyzed their prescription patterns, not a single patient was being given what the gold guidelines or the Indian guidelines wanted them to be given. 96.6% of the patients, which is almost every patient, was on only short-term nebulized therapy or short-acting inhalers. That's a huge number. Hardly a couple of patients were actually given longer acting therapies. Only 2% patient out of these 60 patients had ever been given vaccination, smoking cessation, or were even talked about non-pharmacological management. And 3 out of 60 patients ever had a spirometry done. And what is the importance of spirometry? COPD, unfortunately, is a common disease with a flawed diagnostic criteria. Even in 2025, one is supposed to diagnose COPD on the basis of a lung function test or a spirometry. You don't need a CT scan. You don't need a clinical history. The diagnosis of COPD is based on a lung function test or a spirometry. This is unfortunate because we miss a lot of patients. We know a lot of patients who have emphysema on CT scans or who otherwise have clinical features of COPD. We would not be able to label them as COPD if they do not satisfy this PFT criteria or spirometry criteria of lung function testing or of COPD. So the first question that we need to answer today is, what is COPD? And why is this new definition important? You know, as an audience, whenever someone shows me a definition, my brain just goes blank and I stop looking at that slide. But I think when it comes to the definition of COPD, I want all of you to pay attention here because this definition is actually important. When we were residents, when we were students, we always thought that COPD is a disease of the smokers and COPD is a disease of the airways. You know, nothing else except the airways. There's a chronic bronchitis phenotype. There is something known as the emphysema phenotype. But now we know that COPD is much more than that. So there are certain terms in this definition that everyone needs to go home with and which are very, very important because this has management implications. This is very, very important from the treatment point of view. So COPD is a disease which has chronic respiratory symptoms, which can be cough, breathlessness, which can be sputum production. And the abnormalities in COPD are not just limited to the airways. Even if you talk about airways, they are not just limited to these larger airways, which means bronchitis. They also have a component of smaller airways, which is known as bronchiolitis. And in respiratory medicine, small airway disease is something that we talk about a lot because we have different modalities of treatment of small airways diseases in today's era. And then we also talk about alveolar involvement in patients of COPD. And we know that whenever a patient has COPD, the destruction, the disease process has to be persistent. It is very often progressive and there is airflow obstruction. Also, a new concept which has been launched in the last couple of years is a definition called pre-COPD. We have had terms like pre-diabetes, pre-hypertension, pre-eclampsia for ages together, but there was nothing known as a pre-COPD. Last couple of years, we have had this term which is known as pre-COPD or PRISM, and we now know that the trajectories, the outcomes of patients with PRISM are as bad as patients with frank COPD. So it is very, very important to recognize PRISM or early COPD or pre-COPD, wherein the patient does not have the FEV1 to FVC ratio criteria of less than 0.7%. That criteria is not met, but the patient has either a low FVC or a low FEV1. So this term is something which is very, very important. PRISM, preserved ratio impaired spirometry. And in the years to come, as the definition criteria of COPD are more defined, we will pick up more COPDs at an early stage of disease and probably pick them earlier and treat them earlier. So this is something that everyone needs to talk about now. This is a very, very important slide. You know, till a few years back, cigarette smoking was the only risk factor for COPD. People did talk about asthma COPD overlap, and we used to call that asthma COPD overlap syndrome, ACOS, ACO, and all these terms were talked about. But the latest GOLD guidelines now talk about different ETO types of COPD. So what is happening is they are looking at different risk factors for the development of COPD. And this is very important from an Indian point of view, because they are now looking at not only cigarette smoking associated COPD, which is COPD-C, they are now talking about biomass associated COPD, pollution associated COPD. So, you know, Indian ladies who have cooked on chula for all their life coming to you with COPD, you can label them as COPD-P. The most important subtype of COPD that we see in the Indian subcontinent is the post-tubercular obstructive airway disease, where the patient has probably never been a smoker, but is still behaving like COPD. When you take their history, there is history of tuberculosis in the past. So this is COPD-I or COPD infection or infection associated COPD. Then what was known as the COPD asthma overlap or ACOS or ACO is now called as COPD-A. So these new terms, you know, are very, very important. And if you have no reason, you know, you've taken the complete history and you don't know why this patient has developed COPD, you label them as COPD-U or COPD unknown. So a very, very important classification system, very relevant for the Indian subcontinent, because we have had these patients who had tuberculosis associated COPD, biomass chula angithi associated COPD for years together, and yet the international guidelines did not acknowledge these presentations of COPD. So this is something that is new and that has been launched in the last couple of editions of the GOLD guidelines. Another question that a physician would ask is, I have diagnosed COPD in my practice. I have a patient who is an elderly person, probably a smoker. He comes to me with a chronic history of cough, breathlessness. I have done a spirometry where the FEV1 to FVC ratio is less than 0.7. What next? What am I supposed to do next? And how am I supposed to practice? How am I supposed to manage these patients in practice? So the first step of COPD diagnosis is you have to do their spirometry. The FEV1 to FVC ratio has to be less than 0.7, and this is very, very important. If the FEV1 to FVC ratio is more than 0.7, unfortunately, you cannot label these patients as COPD, even though you know in your heart of hearts that this is COPD. But if the patient has an FEV1 to FVC ratio of less than 0.7, with the right clinical history, with the right clinical presentation, you can label these patients as COPD. And the next thing that you want to see is the FEV1 value of the patients. The FEV1 value of the patient will tell you how to classify these patients as mild, moderate, and severe. So the FEV1 to FVC has to be less than 0.7, and then you look at the FEV1 values. If the FEV1 is more than 80%, this is mild. If it is between 50 to 80%, this is moderate. If it is less than 50, it is severe, and if it is less than 30, it is very severe COPD. This is something which is very, very important, but unfortunately, as Indian physicians, especially those of us who have an background training in internal medicine, our knowledge of lung function testing is dismal. We unfortunately don't know how to interpret COPDs. In your MD medicine final exams, you're supposed to know the most complicated ECGs, paced rhythms and whatnot, but no one asks you a basic, simple, humble spirometry, whether it is an obstructive or a ventilatory or a restrictive ventilatory defect. So it is very, very important to know the spirometry, because this is a very simple test. This will give you a very objective diagnosis. So the first thing that you look for is the FEV1 to FVC ratio, and then to sub-quantify the patient as to how severe the patient is, how bad the patient is, you need to look at the FEV1 values of your patient. Once I have seen the FEV1 to FVC ratio and the FEV1 values, the next thing I need to do is I need to tell my patient, or I need to put a score on the breathlessness. There are two scores which you can use. You can either use the MMRC score, or if you have time in your OPDs, which I'm sure none of us do, you can use what is known as the COPD assessment tool, or the CAT score. So the CAT score is an online score. You can actually do it on your mobile phones. But even if you do not have time to do the CAT score, you can just go back to the good old MMRC, which we have been learning since second year MBBS, right? So whenever I see a patient of COPD, how will I manage this patient? How will I start the management of this patient? I need to make the ABE tool for this patient. I need to make the ABE square for this patient. So the first thing that I will do is I will look at the FEV1 to FVC ratio. That has to be less than 0.7. Then I will look at the FEV1 value of that patient, and I will classify them as mild, moderate, and severe. But the management of my patient is not going to be dependent on the FEV1 value of the patient. This is something which is very, very important. This is something that has changed in the last couple of years. FEV1 values don't always correlate with the outcomes of the patient. You can have a patient who has a very, very low FEV1 value, but the patient is not too bad. On the other hand, you can have a patient where the FEV1 value is not too bad, but the patient is clinically doing very, very bad, So what you need to do is you need to put your patient into either A, B, and E. So how do you see whether the patient is A, B, or E? On the x-axis, you jot down the breathlessness of this patient, right? So if the patient is between MMRC 0 to 1, which means the patient is not breathless in doing his routine activities, the patient is group A COPD. On the other hand, if the patient is breathless on doing routine activities, the patient has to be group B COPD. What is group E COPD? Group E COPD, E stands for exacerbation. The tendon Achilles of COPD management is exacerbations. A good pulmonary physician, a good physician should be able to decrease the exacerbations in a patient with COPD. So why is E, a different subset of COPD, because we know the most important outcome parameter, which is going to define how good or bad your patient is going to do, irrespective of their FEV1, irrespective of how breathless they are, irrespective of what their CAT score or NYHA is, the number of exacerbations that they are having. So what is group E COPD? Group E COPD is a patient who has had even one exacerbation that was so bad that it landed the patient to the hospital, or the patient has had two exacerbations in one last year, for which the patient had to see a physician, for which the patient was not admitted. So irrespective of the FEV1 values, irrespective of how breathless your patient is, if your patient has been admitted to the hospital in the last 1 year, the patient classifies as group E COPD, and this patient has to be given a lot of emphasis, because the chances of this patient dying due to their COPD is going to be exceedingly high. So whenever I see a patient with COPD, I am going to make this diagram for them. Majority of patients who come to a pulmonary physician or a physician in India would actually be group E COPD. Group A COPD in India is treated by quacks, by chemists, by relatives. And unfortunately, whatever we see is all majority group E COPD, which means the patient is a frequent exacerbator, and the patient would come to you with a bad history. And these patients, we call them as revolving door patients. You discharge them, they go out of the hospital, and they come back with an exacerbation very soon. Another practice point that has changed in 2025, and this is something which is very, very important. When should you do HRCT scans in patients with suspected COPD or diagnosed COPD? Now, before COVID, COPD, the gold guidelines for COPD are written for all the countries in the world. The Americans, the Europeans, the Asians, people who are in sub-Saharan Africa, all of us are supposed to follow the gold guidelines. So why did the gold guidelines not talk about HRCTs prior to COVID? They said that, if you talk about, say, that you need to do an HRCT for every patient with suspected COPD or diagnosed COPD, a lot of people from the developing world, say poor countries from Asia and Africa, would not be able to do these HRCT scans, and they would not be able to, it is kind of a limiting factor for them. Post-COVID, the gold guidelines realized that the availability of CT scan, even in the third world countries, is not that bad. So now in 2025, the message is, whenever you suspect COPD or whenever you diagnose COPD, please do their HRCT scans. How does this give you extra information? This gives you two extra information. One, it acts as lung cancer screening, because we all know that the risk factor for COPD, the most common risk factor for COPD is smoking. And smoking is also the most common risk factor for development of lung cancer. So when you do a CT scan for these patients, you're kind of doing a lung cancer screening for these patients. And also, there is something known as lung volume reduction surgery. It can either be done by a surgeon, or it can be done by a pulmonologist like me, wherein we go inside and we put valves to kind of, block certain areas of the lung. So lung volume reduction can be bronchoscopic or can be surgical. And in order to plan a lung volume reduction surgery, you need to have an HRCT of the patient. So this is a very important practice update from 2025 gold guidelines. Whenever you pick up COPD, do not refrain, do not be scared of doing a HRCT chest in these patients. You would actually be doing more service to these patients by doing an HRCT for these patients. Next question. I have picked up COPD. I have done their spirometry. I have seen whether my patient is A, B, and E. I have done an HRCT for this patient. Now, how do I start the pharmacotherapy for this patient? So whenever I start pharmacotherapy for my patient, there are two goals that I need to keep in mind. One is obvious, that I need to take care of their breathlessness. I need to take care of their symptoms. I need to take care of their cough, their dyspnea, and improve their overall quality of life. This is obvious. But the most important parameter that every good physician or a pulmonologist should look into is that you need to decrease the risk of subsequent exacerbations. With every exacerbation, the patient is going to come down at a lower pedestal. The lung function decline is going to be there. Say a patient was on X lung function before an exacerbation, the patient is going to come down to X-1 or X-2. So the goal of therapy is not just to relieve the patient of their everyday symptoms and to improve their quality of life. We need to now talk about decreasing their exacerbations and decreasing their mortalities. Do you know why cardiologists are such rich people? Cardiologists have always talked about mortality. You know, whatever trials of cardiology were there, the Farmingham study, you know, the larger papers on coronary artery disease, the outcome that they took was death, the chances of dying due to their cardiac disease. And that is why everyone is so scared of dying due to a cardiac disease. On the other hand, when you look at respiratory trials, most of the respiratory trials have been very, very soft. We pulmonologists are not, you know, we are very soft people. So we have done trials with FEV1 values, we have done trials with FEVC values or with quality of life. We have not done trials with exacerbations, or we have not done trials with mortality. Thankfully, the pulmonology community is now doing outcomes, you know, we are seeing outcomes in the terms of mortality. So a lot of new trials are now coming out where we look at mortality and exacerbations as endpoints. And it is very, very important that whenever I'm treating a patient of COPD, I need to decrease not just the symptoms of my patient, I need to decrease the exacerbations, and I need to improve, you know, the mortality profile of these patients. So the cornerstone of therapy of COPD is bronchodilators. Bronchodilators can be either beta agonists or can be anticholinergics, and both these agents can be either short acting or long acting. The general trend now is we are moving away from short acting therapy. Short acting therapy for beta agonists is drugs like salbutamol and levosalbutamol. For LAMAs, it is ipratropium. For long-acting beta agonists, it is either salmeterol, formoterol, or indacaterol, and for anticholinergics, it is either tiotropium or glycopyrronium. So the cornerstone of therapy is inhaled bronchodilators, and whenever I'm starting my patient on therapy for COPD, I need to start them on bronchodilators, and this is something which I need to remember. And as I told you, the ABE diagram was very, very important, because the treatment, what you are going to start the patient on, would depend on where the patient is on A, B, or E. What is group A? Group A is a guy where the lung function is not too bad, where the patient is not having too many symptoms. The patient can be started on any bronchodilator. The bronchodilator can be either a LABA or a LAMA. We don't get standalone LABAs or beta agonists in our country, so we don't start them on LABAs. Group B, patient who has a bad lung function and a patient who is extremely breathless, you start them on a combination of LABA-LAMA. Group E is a patient who is a frequent exacerbator or a patient who has a lot of dyspnea. This patient has to be started on LABA and LAMA together, but you don't start inhaled steroids or ICS upfront in these patients. When should you start inhaled steroids in these patients? Inhaled steroids should only be started in patients with severe COPD. If the patients are frequent exacerbators, which means the patient has 2 or more moderate exacerbations in 1 year, where the patient has a blood eosinophil count of more than 300 per microliter. So every patient of COPD has to be started on a LABA-LAMA combination, but inhaled steroids only to be given if the patient is a frequent exacerbator or if the blood eosinophil counts are high. If the patient has a history of recurrent pneumonias, please do not start the patients on inhaled steroids or triple therapy. The patient should be started on a LABA-LAMA combination and not LABA-LAMA and inhaled steroids. How should I use the correct inhaler device? I think this is the most important slide of my presentation. There are 2 kinds of inhaler devices. One is an MDI, which is your pump. And then you have something like a DPI device or a dry powder inhaler, which is something like a rotahaler or a rupihaler, wherein you put in a capsule inside a machine, you break the machine and you start sucking the capsule. So an MDI device or a pump, a hand-mouth breath coordination is required. Whereas in a DPI device like a rotahaler, no such coordination is required. An MDI, especially with a spacer, can be used in acute settings. A DPI like a rotahaler or a loopyhaler cannot be used in acute settings because the patient needs to have good flow rates to start sucking the device inside, to start the inhalation of the drug inside the lungs of the patient. MDIs can be used with spacers, but spacers have a lot of stigma attached to them. Patients don't want to use their inhalers. Patients think they're habit forming. On the other hand, Indian patients are very fond of their DPI devices. They are discreet and handy, and patient don't think that, they kind of develop a stigma or a addiction to these kind of inhalers. MDIs, whenever a high dose inhaled steroid or a LAMA like glycopyrronium or tiotropium is to be used, ideally an MDI should be used, but even DPIs can be used for these patients. So whenever I have a young child, I would either start them on nebulization or use an MDI with spacer. If it is a young adult who has good flow rates, the patient is not in exacerbation, one can use either an MDI or a DPI device. If the patient has come with a acute exacerbation, it is either a nebulizer or an MDI with spacer. The most easy device to use is a DPI device. However, best depositions are seen with MDI with spacer and nebulizations. Last couple of slides. What is the role of non-pharmacological management in COPD? Oxygen is only for patients who have a proven hypoxemic respiratory failure. There are ABG criteria, there are clinical criteria for this. And NIV is only for patients who have a proven hypercapnic respiratory failure. On the other hand, pulmonary rehabilitation, which means exercises, not just extensive exercises, any kind of exercises should be given to all patients with COPD. Smoking cessation should be advised to all patients with COPD. Vaccination, which I will come back to, should be given to all patients with COPD. Dietary interventions, which includes protein supplementation and treatment of sarcopenia, should be given to all patients with COPD. And management of comorbidities should be done in all patients of COPD, and this is something which is very, very important. So smoking cessation, improvement of physical activity is something which is very, very important. What is the list of vaccinations that is now recommended? Till a couple of years ago, it was only the influenza and the pneumonia vaccine. Now for all COPDs, what is recommended is influenza vaccine, COVID-19 vaccine, pneumococcal vaccination, pertussis vaccination, shingles vaccination, and the respiratory syncytial virus or the RSV vaccination. So these 6 vaccines should be given ideally to all patients with COPD, and this is something which has come up recently in the GOLD guidelines. So to summarize, COPD is a systemic disease with the lung at the epicenter. Majority of the patients with COPD don't die of respiratory failure. They die because of cardiac issues. They die because of diastolic heart failure. They die because of coronary artery disease. So never forget the comorbidities in patients with COPD. Diagnostic criteria of COPD, unfortunately, is still dependent on a single test, which is known as spirometry. This needs to be better because we miss out on a lot of patients. And a lot of our physician friends are not very happy doing pulmonary function tests. So I think this needs to be improved. It is not just an airway disease. The lung parenchyma is also involved. The small airways are also involved. So don't just treat the patient with short-acting bronchodilators, drugs like salbutamol, levosalbutamol. Use longer-acting agents which target the peripheral receptors, which target the anticholinergic receptors which are present in the periphery of the lung. The treatment starts with the ABE box, but to make the ABE box, you need the spirometry of the patient and you need the exacerbation history of the patient. LAMA is the mainstay of therapy. If one single agent has to be given to any patient with COPD, it would be an anticholinergic drug, either tiotropium or glycopyrronium. Inhaled steroids are not for all, only for frequent exacerbators, only for patients with poor lung function, and only for patients who have high eosinophil counts. Choose the correct inhaler device. If it is an elderly patient who's a 70-year-old guy with arthritis, someone who has a very, very low lung reserve, there is absolutely no point in giving them an MDI because they would not be able to use the MDI or a DPI device. You probably have to send them home on a nebulizer. So you might have the most expensive drug, but if you choose the wrong inhaler device, you're not going to do justice to your patient. And look beyond the lungs and look beyond the drugs. It is very, very important to talk about non-pharmacological management in patients with COPD. Talk about pulmonary rehabilitation. Even if you don't have high-fangled instruments, just ask them to walk. Just ask them to do anulom, vilom, yoga, any kind of a respiratory exercise. Ask them to stop smoking. Ask about vaccination. If nothing else, you can ask them to have a high-protein diet. So a lot of these patients can actually be helped with very, very simple interventions, right? So this is in a nutshell about the newer things that have changed in COPD in the last couple of years. I bring you greetings from my beautiful hospital in Delhi, NCR. And if there are any questions, I'd be very happy to take them.
Thank you. Thank you, Dr. Thank you, Dr. Arjun. I would like to clarify, as a physician, while discharging our patient of COPD, while discharging from ward, our patient of COPD, how often you write oxygen LTOT, means long-term oxygen therapy for the patient, and how often you write BiPAP therapy per house?
Sure, sir. So LTOT and NIV are very, very important for patients who have advanced disease. So there are certain set criteria for patients who have to be given LTOT. So to have LTOT, the patient has to be in hypoxemic respiratory failure. So there has to be an ABG which demonstrates that the PaO2 is consistently less than 60. Even if it is not as low as 60 or 55, but if the patient has signs of right heart failure, there is cor pulmonale, then oxygen can be given at a lower level, at a lower threshold also. NIV again is a bone of contention. The initial trials of NIV were not very successful in patients even with hypercapnic respiratory failure with COPD, because the amount of pressures that were being given in these trials were very low. But whatever ATS and the chest guidelines now tell us is that if the patient has had 1 or 2 episodes of hypercapnic respiratory failure, which with the patient has been admitted, the patient has end-stage lung disease, there's absolutely no harm in sending these patients home on LTOT and NIV. Not for all patients, but definitely for those patients who are in respiratory failure.
Any other question, query, or comment? Because the session is open for this.
There is a question from Varanasi.
Phosphodiesterase 4 inhibitor. It is also used in COPD. There is one inhalation form of the phosphodiesterase inhibitor. So is it available now here or it is in the pipeline?
So phosphodiesterase inhibitors and management of COPD in India goes hand in hand. The Western guidelines, gold guidelines, and all these guidelines would never ever talk about our traditional phosphodiesterase inhibitors because they were not expensive. So no pharma industry would be wanting to do trials on drugs like leriphylin, aciprofilin, or simple. So now, last couple of years, a drug which is known as ensifentrine. There are trials on ensifentrine now. Ensifentrine is a nebulized phosphodiesterase inhibitor. Even in the US, the cost of ensifentrine per month is $3,600. So although in the latest gold guidelines in patients who have a dyspnea predominant COPD, so where is the role of ensifentrine? A group E COPD who has been optimized on LABA-LAMA ICS still continues to be breathless. So not the exacerbation, but the breathless predominant group E COPD. There is some data on ensifentrine now, but as of now, it is not available in India. Hopefully, probably, sir, in the future, it should be available.
Hello.
Dr. Arjun, it was very
Maybe we have the 8 meteorologists. Can we have the question from them?
Yeah, we will come. We'll come to the locations first. We are trying to finish the question.
Can I ask one question?
GPC Kanpur, just hold on, ma'am. GPC Kanpur. Yeah, we will come for the question, ma'am. Please just hold on. First, we are trying to complete all the questions which has been asked in the Lucknow center. We'll come to you. Yeah.
So my question is, as you quoted in your second slide that there is 100% deviation of what you found in the prescription analogy. So I'm asking about the COPD E group subset, as one of the suggestion is more than 300 of eosinophil counts. So my question is, in the Indian subcontinent, where there are many parallel causes of raised eosinophils, such as worm infestation, how do you quote falsely?
This is one of the most important questions that one is always asked about. So we do not yet have the Indian cutoffs. They were supposed to be published in December 2024. Unfortunately, due to COVID, everything got stalled, and hopefully by mid of this year, we should have the Indian cutoffs. So, we were always thinking about that India, we have a lot of parasitic infections. So our eosinophil counts would probably be higher than, the Western world in general. But if I just give you a preview of the Indian data from what is going to be published, this article has been published by the Lancet Global Health and hopefully should be published by mid this year. Indian eosinophil counts are not different from Western eosinophil counts, despite having a lot of parasitic infestations. Our eosinophil counts were found to be same. This was a multi-center study, and around 20 centers from India participated in it. I was a part of that study, so we all contributed close to around 500 patients each from asthma, COPD, and the general population. So that data is not yet out, but from what I can tell you, the preemptive data, it is as good as the Western world. Yeah.
So now we can move to the center, GPC Kanpur. Please, you can move forward with your questions. GPC Kanpur.
Yeah.
Yeah. Yes, ma'am.
Yes, Dr. Arjun, it was very fantastic presentation. I have one question about the latest drug, that is the this Dupilumab. Dupilumab. What is its role? The subcutaneous injection.
Oh, Dupilumab. So, ma'am, again, I did not specifically talk about Dupilumab because the next talk is on biologicals, and my guru, Dr. Talwar, who is the father.
Has the role in COPD patients as well.
समारोह से डर गया बनाने चला गया था बताने का क्या मैं भर गया आ गया
That because the next talk is on biologicals by the father of biologics in India. So, Dupilumab is a drug which is basically an anti-eosinophil or it's an it was a drug which was designed to be used for asthma. But there are certain patients with COPD who have asthma COPD overlap or where the eosinophil counts are higher than 300. In that subset, that very small subset of patients, there is some data with Dupilumab. In India, we are hard-pressed of using biologics even in patients with asthma, leave alone COPD. So I think hopefully in the years to come, we should be able to use that in our country, but not as of now. It's not available in our country now.
So we have got a question from Varanasi. Can you take a
Yeah. We thank you, Kanpur. We can move to Banaras. The last question.
Right. Thank you. So we have a question from our cardiologist, Dr. Ajay Pandey. What are recent advances in management of right heart failure secondary to COPD? Dr. Arjun, I hope I am clear and audible. The question is, what are recent advances in management of heart failure secondary to COPD? Right heart failure secondary to COPD.
All right, so I think that is a very, very important question because the target audience is physicians today. So the most common cause of morbidity or the most common cause of mortality in patients with COPD is heart failure. So just to sum up the practice points in Goal 2025, routinely beta blockers should not be prescribed to patients with COPD. The safest beta blocker, the maximum data that we have is on metoprolol. Metoprolol is safer than other beta blockers, including carvedilol, nebivolol, bisoprolol. So if a beta blocker has to be used for the management of heart failure in COPD, it has to be metoprolol for both COPD and asthma. A lot of patients who have diastolic heart failure in COPD would respond to CPAP therapy. So you need to think about early sleep studies in these patients and giving them CPAP. We do not start these patients on statin therapy. empirically. So earlier the concept was that because COPD was a state of systemic inflammation and because heart failure is so common in these patients, you should see these patients empirically on statins. So there is no role of empirical statins, aspirin. Aspirin or statins will be started if the patient, if there's a cardiologic indication of starting these two. Right.
Thank you, sir.
Thank you so much, sir, for the very informative session. I would like to request the speaker and the chairperson to the felicitation area for the felicitations. Sir, Arjun sir. So moving ahead to the next session, and that is one of the very important topics, and that is nothing but metabolic associated steatotic liver disease. As we all know, in the rapid emerging area of hepatology is MASLD. Also, the term MASLD that replaces the older term non-alcoholic fatty liver disease, aligning more closely with the increasing recognition that the metabolic dysfunction is the central driving force behind the liver cirrhosis and its progression to the more severe liver condition. So the next talk is regarding MASLD, the physician's workup and the management. And to chair this session, I request Dr. Rajiv Avasthi sir to chair the session. Sir is senior consultant and diabetologist in Lucknow. Sir was also the former chairman API Lucknow. Dr. Puneet Mehrotra sir is senior gastroenterology of Lucknow. Dr. Sumit Rongta sir is professor and head department of gastroenterology, King George's Medical University, Lucknow. I request the chairperson to please introduce the speaker of the next session.
Good evening. After a wonderful session by the respiratory physician, now we have a very eminent gastroenterologist to speak about MASLD. For this, I invite Gauradas Chaudhary. He is the chairman gastroenterology, Fortis Memorial Research Institute. He has done his MBBS from JIPMER and MD and DM both from AIIMS. He has got fellowship of Zika, DAD, WHO. He was a faculty in SGPGI for 25 years. Started EUS biliary ESWL in India. He's got more than 250 publications with H index of 40. He's published 9 books. Not only active as an academician, he's got social work, founded Hope Initiative in 2004, and he's got hobbies, specifically writing Health Adda for column for Hindustan Times for last 13 years. Dr. Gauradas Chaudhary, sir, please use.
Hello. Thank you very much for the kind introduction, and very nice good evening to so many of you. Nice to be back in Lucknow. My talk will have certain parts which would be recent information related. In fact, it will be very difficult for me to match up with my predecessor. He gave a very brilliant talk. But as a oldish person now, getting old, I'll give you some insights into practice on this difficult condition. So it will be a mixture of information and insights. You know, the new terminology, I think what happened with the respiratory talk also, there is a fanciful obsession of giving new terms and new in the terms of how do you change nomenclature. So all along we have known that there has been fatty liver disease, there's an alcoholic fatty liver disease, and there has been a non-alcoholic fatty liver disease. Now scientists have not been able to rest, so they have to introduce something else. So a new nomenclature has come. There is some sense in it, and therefore it might be worthwhile at least knowing how the mind is working on the international front with regard to how to go forward. Now, the diagnosis of MASLD, or shall we say NAFLD, is not difficult. Nowadays, I think most ultrasonographers are pretty good, and they will report a fatty liver disease. So whether there is extra fat or not is pretty obvious. You see the person coming in, I think Dr. Agarwal, for instance, I mean, diabetic, overweight, coming in, ultrasound, fatty liver disease, the diagnosis is not in doubt. You can do more fanciful tests, but you know, that's the way it is. But what has happened is that fortunately, the attention has gone from a very myopic hepatologist's point of view to a more broad-based physician's point of view. The same issue that my predecessor was talking about, the overall effect on health. Dr. Avasthi is an eminent diabetologist, so I know that. These are the criteria for metabolic disorders which have been very simplified and put up particularly for Indian patients. Okay. So I hope all of you know the revised ICMR criteria for overweight is 23.5. So it's not 20 to 25 as it is for the West. So we need to really make people a bit more conscious about fitness, even at lower BMI levels. The fasting sugar should be 100. I think all of you know it better. The blood pressure, we used to have a more tolerant view, 140 by 90. Nowadays, they have brought it down to 130 by 85. Plasma triglycerides, and this is particularly important. So for the last 30 to 40 years, the obsession has been with cholesterol. But you know, the Indian type of dyslipidemia, it's primarily triglycerides, if you see most of your reports. So the attention is actually shifted to triglycerides being the main type of fat which gets deposited in the liver. And of course, there is a HDL cholesterol which has come in. So low HDL is as bad as a high triglycerides. Fairly simple. The pediatric criteria are a little more complicated, but you can always take that up. Now, this is the revised criteria which came, diagnostic labeling that came, I think somewhere in June 2023. Last year, there was an obsession of talks, only talking on this topic. But essentially, the broad term is SLD, steatotic liver disease. So if you want to put a fanciful name, as doctors usually do, so if you have a person coming with a bleed, you call it hematemesis or hemorrhage. So this is only to disguise the patient that, you know, we know something more, which is a bit unique. So here also steatotic liver disease instead of fatty liver disease. But here the two broad groups are, on one side you see the metabolic dysfunction associated liver disease or MASLD. In general, this is the group which is primarily what we used to know as NAFLD with metabolic syndrome. Okay. Now these people are going to either have a high sugar or a high triglyceride, be overweight and so on and so forth. Okay. So the category that many of you would be seeing with hypertension, diabetes and so on. The interesting thing that has happened is with people like many of us in this room, where we would also like to possibly have drinks after the talks. So there are people who are a little overweight, maybe a diabetic popping pills or an hypertensive, also takes maybe alcohol 3 times a week. What label do you give it? It is not alcoholic fatty liver disease because the consumption is not that high. But the alcohol possibly contributes to the problem, and therefore they have made a new category called MET-ALD, that is metabolic plus alcoholic liver disease. And here the issue comes, I think that all of you are seasoned physicians, so I'll talk to you as man to man. You know, the stupidest advice that I have seen, you know, the patients who go back after coming to my clinic, if I told them, now give up alcohol, stop alcohol, I mean, you know, they really look at me, okay, for you, I'm nodding, but I'll decide. So the question is, giving up alcohol may be very required for persons with fibrosis, or when the alcohol calories are adding to your metabolic dysfunction. But otherwise, you know, I think cutting down and focusing on the rest of the lifestyle issues may be also equally important, if not more. Now, here what has happened is there are two other groups. Some people who don't have metabolic problems but have fatty liver disease and they consume alcohol. So they are called alcoholic related liver disease or ALD. It used to be the commonest one earlier on. Nowadays, it's not that common in this part. In some other parts, it's very common. We'll have a chit-chat session after the talk. And then there are a few others like drug-induced fatty liver disease, you know, corticosteroids and so on and so forth, or rare genetic metabolic disorders. So those are minor, but at least the whole body encompasses the rare things also. So we will focus a little bit primarily on metabolic associated liver disease. And here is the decision support tool for steatotic liver disease. Ask yourself in the clinic, does this patient have a cardiometabolic criteria met? So the ones which I listed, 5 or 6 of them, they have been too liberal. So any one of them qualifies. So then you can safely put the person into this category of MASLD. Okay. If the person also takes alcohol frequently, you can call it MetALD. Only thing is, don't punish people who maybe takes 2 drinks in a month or when they come to a API meeting. I mean, that would be a little brutal. Okay. Are there any other causes of steatosis? Certainly. So if there are other causes, alcohol, drugs, they come into that category. If there are none, then it's cryptogenic steatotic liver disease, some of them where you don't find a cause. Now, how do we assess liver disease? Now, I know in Lucknow, there are so many centers doing liver fibroscan. So this is how it is done. I think all of you know that. It's a non-invasive test. You put it here onto the liver, normally take 10 measurements. The new version says 1 measurement is good enough. A new one has come. But it actually has 2 parts, the new machine. So one is called, the one in blue, it's called CAP. CAP is controlled attenuation parameter, which is the assessment of the fat in the liver. Okay. And the other part is the LSM, or the liver stiffness measurement, or the E value. That is the one which tells you, are you heading towards fibrosis? Funnily, for many reasons, maybe because in Europe and America, alcohol is much more frequently consumed, they have started giving less importance to the amount of fat in the liver. And they have actually started giving more importance to the occurrence of fibrosis. Because as very rightly put by my predecessor, even cardiology trials, if you have a hard endpoint like mortality, what they have shown is that liver decompensation and mortality is linked with fibrosis, not the amount of fat in the liver. So that's again a new thing to consider. And so this is the way the measurements are taken, and this is the way the stiffness is measured. I'll go forward. Now there are 2 approaches, and this talk I'm giving particularly to physicians. I'm also a physician at heart. You see, the topic given to me was how to approach and treat fatty liver disease. At the first instinctive question that should come to your mind is, am I treating the disease, that's fatty liver disease, or am I treating the patient with fatty liver disease? You see, it's so important. For instance, if you don't take the second factor into account, you will never assess his motivation and compliance to exercise and lifestyle changes, for instance, or giving up alcohol. So I would urge all of you to look at the larger picture of the patient and not confine yourself to the disease. So from a myopic view, which is a tunnel view, we have to look at the larger view. The larger view is that yes, people with excess fat in the liver, they do die early, at least 7 years shorter lifespan. They have higher frequency of diabetes, hypertension, obesity. There is increased incidence of CVD. By the way, incidentally, the commonest cause of death in fatty liver disease or increased mortality is due to CVD, not due to liver fibrosis, not due to liver failure. And liver-related problems account for only 20%. So the primary problems actually are faced by the cardiologist. And it happens over time and recedes with sustained effort. So that's a very positive thing to be kept in mind. So if you are able to motivate your patients, that would be more than half the work done. And this is the figure which shows you that there is actually an increasing mortality as there is more accumulation of fat and fibrosis. So this is now well proven. So these are long-term studies. So when you're seeing a patient and asking for investigations, what investigations do you ask for? I think I have 8 minutes. I'll hurry up a bit. So LFT and lipids, I'm sure everybody will do. Blood sugar, everybody will do. What is often overlooked is the CBC. And I'll tell you why the CBC is important, because there's one thing in the CBC which gives you an indicator whether fibrosis is occurring. Any young person? Very good, very good. So if you have a low platelet count, be alert. That could be the first sign of fibrosis, okay? And what are the other tests to be done? Thyroid, yes, very important. You can have overweight and fatty liver disease. Anti-HCV, hepatitis C used to be a common cause. Don't miss it out. This year, no, not this year, last year. Very interesting case. I must share this with you. A young boy came very disappointed. He was a doctor. He had applied for the army and he got rejected because his LFT came high. He wasn't grossly obese. Interestingly, his hemoglobin was 12. So I told him this is metabolic, blah, blah, blah. But, he said, no, but I'm perfectly fit. There's something else because, I am doing exercise, everything is okay. So I put him through the checklist. Remember that celiac disease, adult celiac disease, can be associated with fatty liver disease. And his turned out to be IG at TTG to be 50 or 60, He couldn't believe it. We repeated it again, did a duodenal biopsy, and there was celiac, partial villus atrophy. So keep these rare things in mind, but don't think about it in every patient, because otherwise your cost of investigations will go up. Be very practical. Look at the patient. So for physicians, the easiest way to suspect liver fibrosis is by doing something called a FIB-4 score. Are you all familiar with it? No. If you're not, even I don't use it. But to be honest, while preparing for the talk, and many of my physicians use it, there is something called a FIB-4 calculator. So it looks at age into AST. Remember the SGOT, the old SGOT, divided by the platelets. So the lower the platelets, higher the chances with the square root of ALT. Okay. So if you have that calculator in hand, and especially for the diabetologist, I would say it's a must, because you see fatty liver and diabetes overlap so very much. Okay. What do you do? Liver fibroscan. I do it because it's convenient. Otherwise, MR has been well established now, particularly when you're doing clinical trials, because you have to make small measurements of change, which the CAP may not be able to tell you. And liver biopsy nowadays is really not required. Now, with the management part of it, 5 minutes, remember that, there is a genetic predisposition in a lot of people, but 2 generations back, the genes were almost the same. You see, be it in Lucknow or be it in West Bengal or be it in Kerala, the community, the marriage usually occurs within communities. So the genetic pool has remained the same, but there has been a huge exuberance of fatty liver disease. So obviously it meant that against the genetic background, impromptu talks. So I'm quite used to that. Yeah. Shall we start? Yeah. So while the slides come, let's have a conversation. So remember that the focus has to be on lifestyle. And lifestyle means diet, exercise, and sleep. I'll come to the importance of all three. But remember, the focus is there. So that is what the baseline is. Weight reduction is a must. The best data on weight reduction actually comes from bariatric surgery data. That people who have lost weight, their fatty liver improves. Now, only thing is you can't recommend it for every other person, but it's a proof of concept, okay? You can see that. Then comes the first line therapy, medical therapy, vitamin E, pioglitazone, if you're fond of it. I'm particularly not, because it causes weight gain. And here I'm dealing with a person who is already overweight. And saroglitazar has actually come out to be a fairly innocuous, safe, but an effective medicine for reducing fat. You have to remember that it's not good for reversing fibrosis. But nevertheless, if there's extra fat, it does pull it out. The focus still gets back to food and exercise. And here are few things that you must keep in mind. So when you say khana kam khao or weight ghatao, it doesn't mean a damn. I mean, you have to actually give a little more specific advice. Remember that it's the carbohydrates and sugars which get converted to triglycerides, which get accumulated. So many people who are actually taking high fat, the fat may not be the culprit, you know. I mean, in the sense that if you are fond of different types of diet, you know, the keto diet, which is very good for weight reduction, actually has a lot of fat, but you are still able to lose weight. So the focus here is on carbohydrates and sugars. Very important. Increase in fiber. And if you are taking fruits, be very careful. Lot of sugary fruits like mangoes and lychees, they are fruits. So it looks like it's a very good thing, but it has a problem. Cut down alcohol for MASLD. And fasting is again back. Either it's intermittent fasting or the Ramzan. And you know, there is a diet now internationally accepted called the Ramadan diet. So basically you have long periods of fast. Usually most of my Muslim patients here in Lucknow, they come back losing 2 to 3 kgs after the month of Ramadan, and their fatty liver actually regresses. It's pretty good. So fasting is good. The only problem is they sometimes have a very heavy sehri and a terribly atrocious dinner. So that's the only problem. I did this study way back in SGPGI where I got all the staff of the administrative office who were all overweight and put them on a structured exercise diet program. What they need is periodic encouragement. So 2 or 3 times a week, group sessions, and you know, they lost weight. And those who lost weight, you see their liver enzymes actually came down. And this paper, when we sent for publication, they said, yeah, liver enzymes fine, but what happened to the fat? So we actually had to do a paired liver biopsy in some patients. And you see the fat which was there, it actually disappeared in people who managed to lose around 8 to 10 kgs. This was published in an international journal. Many of these simple tips are actually in this book of mine, which is called Health Adda. It's available on Amazon. This is a compilation of the columns I used to write for Hindustan Times, but there is a particular focus on a few things. Remember NEAT. Any of you know what is NEAT? Non-exercise activity thermogenesis. And you know, very interestingly, studies have shown that people who are restless and are following NEAT, they do much better than the 2 hours of intense gym training in the gym. So think about that. And medications, yes, saroglitazar I did mention. More important is that for diabetics, and diabetes and fatty liver coexist a lot, SGLT2 inhibitors have been found to be fairly good. There is generally an apprehension about high frequency of UTI, which I think is a little misplaced. It's about 1%, to be honest. Sir, what's your experience? Is it high? Huh? But the studies show 1 to 2%. So if they're able to tolerate it, SGLT2 is fantastic. It just melts away the fat. And in fact, now they are being used by cardiologists also for cardiac failure. And it's come out to be very safe. So I would, right. And the other one, of course, is the GLP-1s. You know that. So they reduce steatosis. So GLP-1 agonists have 3 good functions. They are anti-diabetics without producing hypoglycemia. They mobilize fat from the liver and they help you to reduce weight. Incidentally, your SGLT2 also is very good because it doesn't produce hypoglycemia. So sulfonylureas are on their way out because they and insulin are the only 2 which produce hypoglycemia, and you don't want to have a problem at home. So this is the data with the GLP-1 agonists. Today a gentleman came, so people will immediately jump and ask me about cost. So, you know, the Ribelsus, as it is available in India, it comes in 3, 7, and 14. I have never given 14 much. We start with 3 and we usually stabilize at 7. The point is that while he's taking it, he also has to focus on lifestyle. Otherwise, you know, you'll keep giving more and more dosage. This gentleman came and he's taking 14 milligrams a day for the last 1 year. And I really suspect what is he doing with the Ribelsus, you know. So, but the fact of the matter is it was a rather high dose to be taken for so long. He was, of course, he had slimmed down, but the fact is that is hardly ever required in my experience, but you people would have more to say. So this is what the treatment pyramid is. So go up the ladder. The interesting thing is SGL2 now is also not contraindicated in non-diabetics. Just like saroglitazar is also now approved in non-diabetics, and GLP-1 is also very much available for non-diabetics. So it's not necessary that they have to have diabetes. This is a saying that do the best you can until you know better. There should have been a K before that. And then when you know better, do better. And that's what I would expect all of you to do. And this is my new book, which will come out next month. It's with the publisher. Most of you as physicians, and if you're a physician at heart, you love this book. So this is the human touch in modern medicine, which is actually coming down in a way. And I think we need to reinvigorate it. Thank you so much, all of you and the audience.
Thank you, Dr. Raj Chaudhary, for excellent deliberation on the topic, which is most talked about now for metabolic disorder, where the gastroenterologist and the metabolic physicians, they have a great role to say. So I would request my co-chair to take the proceedings further.
Thank you, sir. It's always a pleasure to listen to you. Can we have some questions from the audience, please, especially young physicians?
These newer drugs, SGLT2 inhibitors and GLP-1 receptor agonists, have the studies are there, they are useful in reversing the fibrosis, or they are just reducing the...
Very, very good. Very good. So the actual fibrosis doesn't reverse much. Actual fibrosis, a little bit, but not much. Now, the medicine which has come out, which was approved in March this year, is called resmetirom. And that one is pretty good, only approved medicine, but you know, it costs roughly about, I think, $60,000 a month. So when I'm conducting my national NAFL conclave at the end of this week, the 2 Americans who are coming, and one of them is the president of the ASLD, the previous president, he said that we don't use it in US also because insurance refuses to pay for it. It's exorbitantly priced. So if it comes down, the only other hope was actually with the original, the other salt called obeticholic acid, because the 2 trials had shown some regression of fibrosis. Unfortunately, after 8 years of trials, FDA refused to give permission for its use as a drug for fatty liver disease. And that is where we are also stuck.
I think we have Agra branch waiting for the questions now. Agra branch, are you audible?
Yes.
Yeah, you may go ahead with one question, please. Agra, please.
Hello, yes, sir. My question is regarding vitamin E used in the APS section. Earlier, it was very commonly used, but nowadays, guidelines still say it should be used in a treatment of MASH or not. And second question is, what is your experience about the loviglitazone versus pioglitazone in the treatment of this?
What's the question?
Agra, can you repeat the question?
Second question was pioglitazone.
Agra, can you repeat?
Pioglitazone versus loviglitazone. And the first vitamin E. First question was the role of vitamin E. Earlier, it was frequently used in the treatment of MASH or NAFL. But nowadays, recent guidelines say it is not, is of no use. So I want to know what is your experience? Thank you.
Agra, first question about vitamin E.
I mentioned vitamin E. So vitamin E can be your first line drug. In fact, the recommendation is that if you want to save the patient's pocket, you know, and when I come to Lucknow, the patient's pocket matters. Okay. So I wouldn't waste too much of time giving ursodeoxycholic acid or SAMI because they haven't been shown to be very useful. SAMI, Bartley, urso not at all. So vitamin E can be your first line, but that's useful only for fatty liver disease coupled with lifestyle changes. And the dose is usually 2 a day. I find that a little heavy. It's a fat-based vitamin. But that's certainly there. And pioglitazone, I think that pioglitazone is a very good medicine. As I said, 40% of people on pioglitazone have actually a paradoxical weight gain. So you have to really then caution them to be very careful with their exercise and weight maintenance.
Straight away go to Ayodhya branch, please.
Now we
Ayodhya
can go to Ayodhya.
Viren from Ayodhya.
Hello. Hello.
You're audible, sir. Please go ahead.
Can desi ghee be given to these patients? Hello.
Ayodhya, you are audible. Please go ahead, sir.
Dr. Virendra, you are audible. Please go ahead.
मेरी आवाज नहीं जा रही क्या भाई आपको सही
आपकी आवाज आ रही है.
I am audible. Korambai members want to know whether desi ghee can be given to these MASLD patients.
No, it's not clear.
Chat box.
You please put it in the chat box.
Please, chat box. You can use the chat box.
Next will be Bareilly. Please put your questions in the chat box.
डॉक्टर के एस मिश्रा पूछ रहे हैं कि क्या देसी घी ऐसे लोगों को दिया जा सकता है?
You can put.
Okay. Can use the chat box. हो गया.
Viren Singh wants to know, can desi ghee be given to the patient?
Which inhibitors?
Desi.
Desi ghee, yeah. I'll come to it. So desi ghee earlier was thought to be a calorie dense, substance, food item. So people said, no. It's almost like saturated fats. It is saturated fats. There has been some rethinking on that. And therefore, our leading hepatologist, Dr. Sareen, seems to say that a little bit of ghee could actually be beneficial. Although my American colleagues, Arun Sanyal and Chalasani, who will be coming, they are dead against it. So I think that the truth is usually somewhere in between. I don't think that restricting desi ghee to extreme limits would be sensible in an Indian practice.
Now over to, which one? Dr. Smita. Dr. Smita is there from Bareilly. Please, Bareilly, go ahead.
Bareilly. Sir, please unmute yourself. Sir, please unmute yourself. Bareilly, please unmute yourself. Bareilly, unmute yourself, sir. Sir, you have to unmute. Sir.
Let's get finished.
Yeah, please go ahead, sir.
Okay, now getting from the physician from Bareilly, my question is the doses about the pioglitazone. Because yesterday in the conference at Diabetes India and then the Ahmedabad, they recommend the doses say 30 milligrams to 45 milligram minimal doses to be effective for fatty liver. So I think that's a very high doses. And the speaker says that below that there is no effect on the fatty liver. But those will cause the hypoglycemia. So what is your comment about the doses of the pioglitazone in these case of the MASLD?
Sir, actually, the first trial that was done was called the PIVENS trial, P-I-V-E-N-S, PIVENS. So that actually looked at pioglitazone, vitamin E, and a placebo done by Dr. Arun Sanyal. It showed that actually pioglitazone was useful, but paradoxically, they had also used vitamin E as a placebo, co-placebo, and they found vitamin E was also useful. So pioglitazone was good, but therefore with so much research, now with other molecules, it may not be necessary to use high doses of pioglitazone. So that would be my humble request. Think about the other new molecules which has come, especially like SGL2.
Over to chairpersons for concluding the session, please.
Can I just tell a 1-minute story to the young people?
Yes, sir, please.
Sir.
Please, sir.
So the reason why you must look at the patient and not at the disease. So aggressive fellow from UP, in my clinic in Lucknow, he came to me about a month and a half back. And he came, he was obese, he had fatty liver disease, and his main symptom was that he has lack of libido. His wife was very unhappy. So obviously all the tests showed fatty liver disease. There was a lot of extra fat. And I put him on fatty liver disease management, gave him diet, lifestyle advice. You know, he came today. Where is that boy here who's sitting with me today in the clinic? You know, so educative. I was focusing on the fatty liver disease. And he came and told me, आपकी दवाई से कोई फायदा तो नहीं हुआ, बल्कि हमारी ना अब कमजोरी और बढ़ गई है. So I said, अच्छा क्या हुआ?
Thank you so much, sir.
Just 1 minute, 1 minute. This was not my fault. So you know what? He was in a room sharing with somebody else, and his partner recorded his sleep on a video. And the partner told him that, you know what? तुम्हारी ना बीच-बीच में सांस रुक जाती है. And I found that he had classic orthotropic sleep apnea. And now, you know, if you have sleep apnea, you feel tired in the morning. In fact, throughout the day, he was not doing exercise. He was sluggish. He obviously had low libido, you know, in the sense he was so tired all day. But the diagnosis was made by just the video. So I'm trying to tell you that when you get a person with that spectrum of disease, anything is possible, from celiac disease to orthotropic sleep apnea. So keep the patient in focus. Thank you so much. Sorry for the
there is a question from Merit, sir. Sir, there is a question. What fruit you advise as they contain fructose, which have different metabolism in liver, from Merit?
Very good question. So fructose has been found to be far worse than actually sucrose. Incidentally, this has been the last 5 years research. That's the reason why in the Western world, they're up against fruit juices. And in India, somehow we have become a dumping ground for fruit juices because we think that's a health drink. It was once upon a time promoted by the Tropicana ads, you know that? And all the good, lovely fruit juices. If you have to take fruits, it has to be fruits, not fruit juices. And that's an absolute must. Thank you.
Thank you so much, sir.
Thank you, sir. Thank you.
Thank you, sir, for a nice talk. I'll request the speakers and the chairpersons to move towards the felicitation area. So the next session is regarding the treatment of asthma. What if my patient is not improved, even if I have given bronchodilators, I have given steroids, I have given nebulization, and still my patient is not improving? So is there anything in the current scenario which can be offered to such type of the patient? And the answer to the question is yes, and that is the biologicals. So the biologicals, these are the therapies which are designed to target the specific molecules or the cells which are involved in the inflammatory reaction of this process of asthma. So to talk on this biologicals in asthma, which biological, when and how. So to chair this session, I request Dr. B.P. Singh, sir. Sir needs no introduction. Sir is Senior Consultant and Director of Midland Hospital, Lucknow. Dr. P.K. Pandey, sir. Sir is Senior Consultant Physician, Lucknow. Dr. Sanjay Arora, sir. Sir is Senior Consultant Physician, Lucknow. Sir, please move ahead. Requesting the chairpersons to please introduce the speaker.
Thank you for this invitation and good evening to all of you. And as Dr. Yadav has mentioned that in the management of bronchial asthma, once you have exhausted your therapy with LABA, ICS, and even then patient is not controlled. Most of the patients you know that can be managed with this therapy of the LABA, ICS, but around 10% patients, in spite of all the precautions and treatment, they are not controlled with the conventional therapy. Then you need to add something. And to add this, today we have Dr. Deepak Talwar, and he's a very big name in the field of pulmonary medicine. All over the country, he is the topmost stalwart in this field, and also he has been the lighting and guiding force to all the youngsters in the field of the pulmonary medicine. I will not go into the detail. I'll just ask Dr. Talwar to start his presentation. He will be talking on the biologicals in asthma. Thank you.
Thank you very much. Good evening, everyone. And thank you, Dr. Sanjay, for calling me here and giving me the most favorite talk, which is biologicals, and that too in asthma. And I think, I do not know how many of you are using biologicals, but I'm sure all of you must have at least heard that there are expensive drugs available in the field of respiratory medicine, which is being used these days. And of course, the most important thing is, who are these patients in whom you can use them, when you should use them, and then how you can use it and for how long you can use it. I think these are the couple of questions which are in the minds of the patients themselves as well as the physicians who are treating them. The sad part of the story of asthma is that prevalence continues to rise, asthma continues to make the patient suffer, and the biggest fact is every second patient who dies of asthma all over the world, that death comes from India. We lose one patient out of the whole pool we are talking about the world. We are the leaders in asthma deaths. And we are not able to decrease its prevalence. It is increasing and it's not showing any downward trend, expectedly because of the various things which are happening around us. My talk is on biologicals. What are biologicals? Biologicals are being used practically in each and every sphere of medicine now. These are targeted missiles. You produce an antibody which is targeted for one particular cell or a cytokine, which if it once delivered into the body, it will hunt for it and neutralize it. I think very rightly, as all the warfare missiles are used, you set the target, which is the building to be destroyed, it will just go and destroy that building. So we have three biologicals for asthma to be used. One is called, which is the oldest one, omalizumab, which came to India in 2008. Then mepolizumab, which came into India in 2016. And then finally the benralizumab, which came in 2020. Now, what are these biologicals? So we know that asthma is conventionally connected to IgE. So IgE, wherever it plays the role of a villain and causes symptoms in the patient, exacerbations in the patient, and make their life miserable, you can neutralize that IgE by giving them what is called as omalizumab. So this monoclonal antibody is actually directed against IgE, and it binds it and then neutralizes it so that it cannot cause harm. But every IgE is not harmful. The second most important is the cytokine, which is interleukin 5. And there are two monoclonal antibodies which are available for it. That is mepolizumab and benralizumab. So if it is primed for IL-5, then circulating IL-5 will be neutralized by a monoclonal antibody, which is IL-5 antibody, and it is called mepolizumab. IL-5 cytokine goes and sits on the eosinophil and breaks the eosinophil so that it releases all cytokines to cause havoc in the body. So IL-5 receptor blocker, the receptor which is on the eosinophil, is an antibody, again a monoclonal antibody, and goes on, sits on the eosinophil site, eosinophil on the site of the interleukin 5 receptor, blocks it, so that whatever is the level of interleukin 5 in the blood, it finds no place on the eosinophils and cannot do that cascade of inflammation, which is supposed to cause a lot of damage to the airways, lungs, and many other organs of the body. The monoclonal antibodies are primarily produced by murine protein, and it is combined with a human protein. So if there is a murine protein, it can cause an anaphylaxis, it can cause an allergic reaction. But the one monoclonal antibody, which I think was asked to
Arjun, was that dupilumab, which is a totally human monoclonal antibody, does not have any foreign protein in it. Rest of them are like 90% human protein, 10% animal protein. Potential for anaphylaxis is there, but we have never seen an anaphylaxis in the last almost about 20 years of use of omalizumab. So the first question is, when do we use it? So we use it in the patients who are in step 5 of GINA. What is step 5? Patients are on high dose inhaled corticosteroids and a LABA. I think you can think about it, 800 micrograms of budesonide and above, and a formoterol. Or patient is on medium dose ICS plus LABA plus LAMA. So that is like between 400 to 800 microgram of budesonide, then formoterol, and then tiotropium or glycopyrronium. Any patient on this treatment, if is continuing to suffer with asthma burden, which is in the form of symptoms, exacerbations, and need for oral corticosteroids, is a candidate for biologicals. So this is a patient you can easily recognize in a practice that he is on these drugs, high dose ICS, LABA and LAMA. And these patients, when they deteriorate, our option is to give them oral corticosteroids. And the idea of you introducing the biologicals is we do not want oral corticosteroids to be given to this patient, even in the low doses or in the burst, which we most often use in our daily practice. We have other options like montelukast and azithromycin, but not very effective. Now the question comes, why we don't want to use oral corticosteroids? So oral corticosteroid, typically we give to asthmatic patients for 5 to 7 days, and the dose is between 30 to 40 milligram per day. That's called an OCS burst. So even if you are using 1, 2, or 3 bursts in a year, you nearly carry about 10% higher risk of fractures, gastric ulcers, GI bleed, and hypertension. But if, God forbid, the bursts are more than 4 per year, then this risk almost increases to 2 to 3 times and is between 20 to 30% for fractures, GI bleed, hypertension, diabetes, cataracts, and obesity. We don't want OCS burst also, not to talk about low dose maintenance. There are so many people who are on 5 milligram of prednisolone or 7.5 milligram of prednisolone and very, very happy with that. But that is what is going to have a long-term morbidity related to OCS as well as a mortality. And a typical real-world studies, most of these patients receive oral corticosteroid bursts, nearly 50% of them in the year when they are studied. And many of them are actually have a severe asthma and are on long-term corticosteroids, and that number goes to about 60%. So you can see that about half of 50% of patients of severe asthma or uncontrolled asthma do get oral corticosteroids. So does any patient who is taking this medicine become eligible for this medicine to get these biologicals? No. It's a very circuitous road which we need to go through to pinpoint those patients, pick up those patients who are ideal or suitable candidates for that. And that is a patient who has got uncontrolled symptoms, but then we have to navigate this way to reach finally severe asthma by 5 steps. And these are looking at diagnosis. Are they real asthmatics? Believe it, 25% of these patients who are on every possible drug available asthma patients don't come up as asthma only. They have multiple comorbidities, diabetes, hypertension, osteoporosis, myopathies, God knows how many of them. And if you don't treat them, they'll continue to be breathless. They don't need actually biologicals. They need management of comorbidities. Once we have done all this and navigated our way to reach severe asthma, we reach the diagnosis which is called as severe asthma, but this is a retrospective label, what we are talking about. I think I'm stuck here in the slides. Can we move the slides or it's still stuck? Okay. I think it's at the back end. So we have come to step 5, which is severe asthma. We have navigated our way where we have tried to rule out all other things which can make the symptoms of asthma look like worse, but they are not because of airway inflammation, but because of the associated conditions, patient not taking treatment, and so many other things which are happening to these patients, which are like comorbidities, I said. Okay, you start again. Okay. हाँ हो गया ना नहीं नेक्स्ट आ गया हाँ नेक्स्ट कर रहा हूँ ओके 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 okay so all these things which are there which make the patient's life miserable but is not because of the airway problem, not because of the inflammation in the airways, are called difficult to treat asthmas. So you really need to work hard, and it takes nearly 3 months to do that. That is why the diagnosis label of severe asthma is a retrospective. So any patient on step 5 asthma who's continuing to have exacerbations, poor symptom control, and once you try to decrease the high dose inhaled corticosteroid, they immediately go back and develop exacerbations, and they do have biomarkers to tell that biologicals will work. Patients on oral corticosteroid maintenance are the definite ones who need to be switched to biologicals. How do we identify in our clinical practice that these are the patients who are going to be benefited by biologicals and they are on step 5? So this is called type 2 severe asthma. So this is the allergic atopic asthma. Generally, the onset of asthma is either in early childhood or early adulthood, and they have a lot of allergic comorbidities along with it. Allergic rhinitis, atopic dermatitis, urticaria, ABPA, EGPA, all these things are pointers toward the underlying T2 inflammation in these patients, which can be targeted either by oral corticosteroids or by biologicals. And of course, the shift is to biologicals. So we do certain tests which are called biomarkers, and you know biomarkers are just being thrown onto the on us to see that what kind of biomarkers are coming from this patient. Are they T2 biomarkers, T2 inflammation biomarkers? So they are basically eosinophils, IgE, specific IgE. Eosinophils can be in the blood or they can be in the sputum, and of course we have another one in the bone marrow, which is causing maturation of the eosinophils, that is the periosteum. But most of the times what we use is a blood eosinophil of 300 or more than 300, pheno more than 20 or equal to 20, and sputum eosinophils more than or equal to 2%. So any patient who shows this biomarker positivity is T2 inflammation and is a candidate for biologicals. But another important aspect is looking at comorbidities, which I just now told you: rhinitis, sinusitis, nasal polyposis, urticarias, atopic dermatitis. All these things also tell us it's a T2 inflammation which is going on, and you need to consider them for biologicals. But when do we test this? So eosinophil count 300 may not be the sacrosanct, because eosinophil is exclusively sensitive to oral corticosteroids. If you have given the patient, it will take about 2 weeks to come back. So you should test when patient is not on steroids or after 4 weeks of stopping steroids, or if you are not able to stop it, try to bring it down. And the way the eosinophils rebound, that tells us that it was a T2 inflammation and steroids were actually bringing them in control, and you have just decreased the dose and they have gone back again to the previous one. So this is a study we try to look into India, that what kind of severe asthma exists in India. 90% is this so-called as T2 high asthma. These are like either IgE mediated or eosinophil mediated. And for both of them, we have a monoclonal antibodies which can be targeted to kill either or neutralize IgE or eosinophils. And almost 90% of patients are actually eligible for biologicals. But of course, the cost is the major factor there. Then how to choose? That's the third question, how to choose. So we need to identify what is the driver. Is it the IgE? It is the eosinophil. It is interleukin 5, interleukin 4, or interleukin 13. I think it will be too much for me to get into the interleukins here, except for the postgraduates who need to know that. But the eosinophil is primarily the one which is the precursor of many cytokines, but IL-5 is primarily a cytokine which is driven across the airway inflammation and causing a lot of eosinophilic inflammation as well as recurrent exacerbations and need for oral steroids in patients with asthma. We have targeted all of them, IgE by anti-IgE omalizumab, IL-5 by mepo and benrali, I said, and IL-4 and 13, which is by dupilumab. And now we have also a newer ones which are coming up, which work at the level of respiratory epithelium. You don't have to go to downstream. Work at the upper level, block everything else, and then it is immaterial whether interleukin 4 is the villain, interleukin 5 is the villain, interleukin 13 is the villain, or interleukin 17 is the villain. Whatever is this, they block it right on the top. Hopefully, we'll be getting it in a couple of years in India. So then we ask ourselves that which one we are going to give it to the patient. It's a T2 inflammation. It is step 5 asthma treatment. Patient continues to suffer with exacerbations, poor asthma control, poor lung functions, requiring oral corticosteroids and blah, blah, blah. What do you do? So we choose them to match with the expectations of the patients. And this is there's no head-to-head trials. So you may say that we are trying to look into individual drug from a different perspective. But yes, all of them are able to reduce about 25 to 50% of oral corticosteroid dosages. Some of the drugs like benralizumab completely eliminates the need for oral corticosteroids in 1 year time. All of them are able to reduce exacerbations by 50 to 70%. All of them have potential to improve the asthma control, lung functions, and as well as improvement on comorbidities. So if you give it to control asthma, there's nasal polyps, sinusitis, rhinosinusitis, everything improves. It improves their angioneurotic edema, it improves their urticaria, it improves idiopathic urticaria, and even food allergy, for which omalizumab is the only biological which has been approved. We don't have anything for food allergy. For EGPA, now the treatment of choice is to either use mepolizumab or benralizumab. And this is again a very difficult situation to treat these patients. Are these biologicals safe? That's the next question which comes to, in India, have you used it? Is it safe? So you can see Arjun's name on omalizumab. We published this data of more than 100 patients out of 300, which completed 1 year. Absolutely safe, improved quality of life, lung functions, reduction of exacerbations, and OCS dosages. Then we published also on benralizumab. So again, a very, very effective drug, very, very safe drug to be used in eosinophilic type of severe asthma patients. So this is in nutshell what I'm telling you, that if you have a childhood onset asthma, patient is sneezing like hell with allergic rhinitis, patient has idiopathic urticaria which refuses to go away without steroids, patient has a food allergy, anything they eat and they develop allergy, or they have nasal polyposis, is an ideal candidate for omalizumab. If the patient has a little late onset asthma, they have comorbidities like EGPA, hypereosinophilic syndrome, or nasal polyposis, then mepolizumab is the drug of choice. If they have even little later onset of asthma and they have a lot of nasal polyposis, CT scan shows a lot of airway mucus impaction in the lungs, and they also have hypereosinophilia or CEP, the benralizumab is the drug of choice. Once you start them, you require minimum of 4 months to see the effect of the drug. The entire villain of the asthma pathogenesis cannot be neutralized over one injection. You need to be a little patient, wait for 4 to 6 months, and then evaluate. Symptom burden of asthma has decreased or not? Exacerbations have decreased or not? Are there any side effects of the drug or not? Has the lung functions improved or not? Has the total polypharmacy going on to the patient has been reduced or not? Because they are already on 5, 6, 7 drugs. Have been be able to bring down to maybe 1 or 2? Even that makes a lot of difference. And then finally, Patient satisfaction as concerns is a very, very important. And if we find at 4 to 6 months that the patient is doing good response, we continue. If they do poor response, we stop the biologic and try to see that maybe the choice was wrong. We need to give the other biologic. And if we are not clear whether the patient is good or not, he says, I'm a better room, but not so much, then continue for 1 year and then take a call. So this is my concluding slide, which tells you when to give. Those asthmatics who are on GINA step 5 treatment and do not have any unaddressed, difficult to control asthma morbidities or related to diagnosis or anything, all has been done and they are on GINA step 5, then they are the ones who can or should be given biologics. Now, which patients? At the moment, we have only T2 patients, T2 high patients, nearly about 80 to 85% all across India are T2 high patients. Then how to choose? Look at eosinophils, look at IgE and specific IgE, as well as various kind of sensitizations to various allergens. And then you can choose between omalizumab or mepolizumab or benralizumab. Then which anti-eosinophilic drug? It depends upon comorbidities, the cost of the therapy, as well as expectations of the patient. And what do we expect? What I think that's the most important thing, that if you are spending that kind of a money, the first question which the patient is going to ask is, how am I going to be better? Or what should I expect at 6 months? So you do expect to get significant reduction in asthma-related exacerbations, which definitely are costly. It is definitely going to decrease and make perhaps the zero need for oral corticosteroids, which is a long-term thinking about it. And of course, improvement in daily quality of life of these patients. Then last question, when to stop biologicals? So these days we are talking about remission and cure in asthma. What is remission and cure? I am on drugs, but I am as good as every other person in this hall who does not have asthma. And when it goes off treatment, that means I am cured. So we have reached destination remission already. All 3 biologics, 4 biologics, 5 biologics have been shown to get remission in more than 50% of patients. But what we are looking forward to is cure of asthma, which generally we talk about only in children, but now we are going to talk about in adults with the advent of these biologicals. Thank you very much.
Thank you, Dr. Deepak, for the excellent presentation. If there are any questions from the audience.
Yeah. Thank you very much, sir, for a very nice question. We have a question from Varanasi audience. Is there a difference between asthma, well-controlled asthma and asthma in remission? Hope I'm audible, sir. Very nice talk.
Yes, sir. Please go ahead with your question.
Yeah, is there a difference between well-controlled asthma and asthma in remission?
Okay. So yes. So when we talk about remission, we don't want to talk about only a well-controlled asthma. Well-controlled asthma is a patient who does not have exacerbations, patients who does not require oral corticosteroids, patients who do not get into hospitalizations, as well as these patients are basically maintaining good lung functions. That is called complete remission. So complete remission is more than well-controlled asthma. It's a little more than that. But at the moment, when you talk about on treatment, then it will be called remission on treatment or in a very well-controlled patient.
Thank you, sir.
Next, we have done with Prayagraj. I will move to the next question to Gorakhpur. GPC Gorakhpur, you have any questions? GPC Gorakhpur, please unmute yourself. GPC Gorakhpur. Yeah. GPC Gorakhpur, any questions? Yeah, please. GPC Gorakhpur, unmute yourself. Yeah, yes, sir.
It's okay.
Okay, so we can move to Meerut. GPC Meerut, any questions?
Hello, I'm Dr. Tomar here.
Yes.
Regarding the prognosticating factors like different, like omalizumab, mepolizumab, and we are having benralizumab, any prognostical markers that we can use that this is working, this is not working, or this will work or this will not work. As you said in the polysinusitis, benralizumab is better. And like in this depemokimab, again, if patient is having this polyposis, nasal polyposis. So any other markers, can you elaborate for us?
I'm not very clear, Viruttam, because I couldn't hear you clearly. So anybody has heard actually the question?
GPC Meerut, can you repeat the questions once again?
Sir, any prognostic markers regarding these maps?
You can use the chat box. Can you use the chat box? Yeah.
I'm
Meanwhile,
sorry.
anyone from Lucknow, anyone from Lucknow? Yeah, please.
Let the question come on the chat box from Merit. Yeah.
Sir, my question is that suppose asthma if not control, there may be chances of ABPA.
Chances of ABPA?
Yeah. If not control, there may be chances of ABPA.
Yeah.
Suppose if we start biologics in this condition, may it be harm or it be beneficial?
So ABPA is a comorbidity, and again we need to consider that because we have a protocols to treat ABPA. But in ABPA, which is intractable, which does not respond to the standard therapy, already there are trials telling us that omalizumab is possible to use them. In fact, we used it in 2010, long ago. But the problem is when you stop them, the ABPA relapse comes back again. There are people who have even used mepolizumab for these patients because they also have hypereosinophilia along with it. So it does not cause harm, but the question is that you need to treat that fungal part of it with the antifungal, which is the major treatment to be given for the patients of ABPA to decrease the fungal load. The person is allergic to fungus. The fungus is inside his body. So you need to decrease the dose of that the burden of that fungus. So you need to use antifungals along with it. So if you ask me that have we used it without antifungals? No. Add on, particularly in difficult cases of ABPA, who keep on getting relapses again and again. Is there a question?
Okay, sir, there is a question from Agra. MAB inhaler form with or without other drug?
What is the question?
MAB inhaler form with or without other drug?
MABs with or without inhaler? So inhaled biologic. Oh, okay. So there is no inhaled biologic available at the moment. We are only working on a subcutaneous injection for once in 6 months. I think that is what is coming up in maybe another year or so. So that patient doesn't have to take injection every month or every 2 months. It will be like once in 6 months and done. So I think that's a great idea, but inhaled MABs are not there.
Sir, there is a question from GPC Meerut. Prognostic markers for biologics.
Prognostic markers in biologic. Okay, so I think what it means is that are there any markers which tell us that this patient is going to do good and you can invest money on that or not? So these are the biomarkers which we are talking about, that the eosinophil count, more the merrier. So if you have 300 and above, perfectly, it is an indicator that the patient, prognostic indicator that patient is going to do good. And also exhaled breath nitric oxide, which is like above the level of 20, also indicates that the patient is perhaps going to do good with the biologics. So these are the two main biomarkers, but I think the biomarker which we are talking about is oral steroids. The patient who does good on oral steroids, and the moment you start decreasing steroids or trying to withdraw steroids, they actually go back into relapse. So if those situations are there, they are also a marker that this is a T2 high inflammation which responds to oral corticosteroids, and all you want is OCS to be off the list so that he doesn't develop a side effects of it.
Sir, for individual MABs, for not combined, for like we want to use omalizumab in this patient, we want to use mepolizumab, we want to use this benralizumab, we want to use ipilimumab.
GPC Meerut, just sorry, we are not taking next question. So sorry, we'll move to the next topic now. So thank you, sir. Thank you.
Thank you very much.
Any question?
Thank you so much, sir, for the wonderful presentation. So requesting the chairperson and speakers to move to the felicitation area. So moving ahead to the next session, and this is something, there are two critical conditions that are often present with similar clinical features, but have distinctly underlying different pathophysiology, different cause, and different treatment. And these are nothing but intestinal tuberculosis and inflammatory bowel disease. Both of these conditions are significantly contributors of gastrointestinal morbidity, and distinguishing between the two can be challenging for clinicians, particularly in the regions like India, where the TB is still endemic. And to chair this session, I would like to call Dr. Atul Malhotra, sir. Sir is Senior Consultant Physician and former Chairman, Lucknow API. Sir is current the Treasurer of the UP API. Dr. Sameer Gupta, sir. Sir is Senior Consultant and Chairman-elect of API Lucknow. Professor K.K. Savlani, sir. Sir is Professor in the Department of Medicine, King George's Medical University, Lucknow. The requesting the chairpersons to please introduce the speaker.
So we request people who are standing on the back, I request please take your seats. There are a lot of people which are standing in the back. I request everyone to please take your seat. Please take your seat. Please take your seat. Sir, please.
Is it? It's not working, sir. Sir, mic is not working, I guess probably.
Next speaker is Dr. Gaurav Pandey. He's a professor, Department of Gastroenterology, SGPGI, Lucknow. He secured first rank in All India Super Specialty DNB Gastroenterology examination. He's a gold medalist at the 17th convocation of National Board of Examinations. He has additional training in bariatric endoscopy at Erasmus Hospital under Professor Jacques Devere. He is a visiting consultant, John Hopkins Hospital, Institute of Medicine, Department of Hepatology and Liver Transplantation. He is visiting at Royal Melbourne Hospital and Austrian Repatriation Center, Melbourne, Australia. He has a fellowship in gastroenterology and hepatology, focused on liver transplantation. Over to Dr. Gaurav Pandey for the next talk.
Good evening, everybody. Sincere thanks to Professor Sanjay Tandon sir and the chair. It's been an honor to give this talk to this august audience. It's great. It's my privilege to be talking in front of Professor Gauradas Chaudhary sir. We have learned so much from him during his stay at SGPGI. So coming to the topic of intestinal TB versus IBD. Actually, TB is a great mimic. It mimics almost all the diseases that we have in most of the systems. Before we move to this, I'll just wish you happy Valentine's Day. This is the Valentine weekend. Nobody talked about that. So the question is for youngsters, why is it important? Sir has arranged this talk at the Valentine weekend. And why is that? So what is a romantic disease? What is the romantic disease? Anybody, any guesses? So tuberculosis is being named as the romantic disease. You know, world over, tuberculosis is the romantic disease. It initially spread by contact, and so it was called romantic disease. That's how the name romantic disease came for TB. A very interesting take on this. So, you know, like romance, again, TB is a very clever disguise. Cunning has cunning deceived, and it masquerades like for any other disease beyond any logic. So it's very difficult to diagnose TB. And coming to Crohn's disease, first TB existed in intestine, then in India, slowly Crohn's disease progressed, and now Crohn's disease is found at the same site. And in the 21st century, we are talking about TB on Crohn's disease. So are we there just, or we are just a step behind? Intestinal TB, why this dilemma? Why this question? Why this talk? The problem, it's difficult to diagnose. And why is that? It's because it is a paucibacillary disease. Unlike pulmonary TB, the diagnostic tests accuracy are very, very low. So it's very difficult to diagnose. And TB, being a great mimicker, causes inflammation in the gut, mimics inflammatory bowel disease. Now coming to the Crohn's disease, or the prototype of inflammatory bowel disease that TB mimics, again, it is not a typical example of any autoimmune disease. The issue is, like TB, there are poor antibody and serological tests to diagnose Crohn's disease. You know, it's easy to diagnose rheumatoid, but we don't have any such tests to diagnose Crohn's disease. That is the whole issue. But why do we need to differentiate? It's important to differentiate because people who receive TB, their risk of developing strictures, or they had a higher risk of undergoing surgery if not treated properly. The risk of progression appeared to be confirmed because of ATT themselves and not because of the disease per se. So misdiagnosing TB and Crohn's, you give steroids, what you end up with is with dissemination of TB. The other issue is, if you delay TB treatment, you may have stenotic complications, early need for surgery, and ATT-induced hepatitis risk always remains. So it's very, very important to go all out to differentiate the two diseases. Is it TB or is it its mimicker, the Crohn's disease? So let us solve an enigma. We'll just give you one example. A patient recently seen by us, 28-year-old male, young person, case of neurofibromatosis. 1 year history, perianal pus discharge, 3 months history of increased discharge, intermittent fresh bleeding PR, intermittent fever, and weight loss of 10 kgs. Now, colonoscopy showed deep longitudinal and transverse ulcer and an ulcerated stricture. In biopsy showed chronic inflammation, no acid-fast bacilli. The gene expert was negative. So, we looked at the scans. Scans showed right istiorectal fossa collection and a collection communicating with the rectum. So there was a sinus tract and there was a istiorectal abscess. Now we'll go through each of these paradigms. We look at the clinical, endoscopic, histological biopsies. But at the far left corner, our patient had hematochezia. He had perianal disease, chronic inflammation, left and right, multiple segments of colon involved. His chest X-ray was negative and he had a perianal disease. So what is the potential likelihood? TB or Crohn's? Crohn's, isn't it? Yeah. So clinically, in this picture, we do suspect that it should be Crohn's disease. But we got a CT chest and there you see bilateral tree in bud appearance. And he was treated with ATT and he improved. So compared to X-ray, CT chest improves the diagnosis of TB by more than 30%. So again, CT chest may be required to differentiate the two conditions. Coming to clinical features, TB, you will have all the constitutional symptoms, fever, weight loss, evening rise of temperature. If he has pulmonary TB, pulmonary symptoms, cough, sputum, all would be there. Patient may present as an acute abdomen, subacute intestinal obstruction, or a perforation. He may have a cocoon formation. There will be a palpable lump, big lump in the abdomen. It commonly affects the ileocecal region. Concomitant pulmonary involvement may be up to 1/4 of the patients. And around 15-16% of the patients may have ascites. Compared to Crohn's disease, they will have malabsorptive symptoms. The duration is most of the time longer than TB. They may present with fistula. They will have a relapsing and a remitting course, a prolonged disease course. They may involve more than one segment of bowel. They may not be limited only to small intestine. They may have multiple parts of small intestine and maybe large intestine involvement. They commonly have extraintestinal manifestations, perianal disease, diarrhea, and hematochezia. So this, in a nutshell, is the different clinical features of these two mimics. Studies have shown that prolonged duration chronic diarrhea, hematochezia, extraintestinal features, and perianal disease favors Crohn's, while fever, constitutional symptoms, shorter duration, and ascites favors tuberculosis. So this is in a nutshell the whole paradigm. The features in the red favors TB, the features in the blue favors Crohn's. In between, we have some non-significant features. So as mentioned, ascites, short duration of history, favor constitutional symptoms favors TB, the rest favors Crohn's disease. So clinical features for undergraduates, GITB, short history, pulmonary symptoms, peritoneal involvement, ascites, abdominal lung cocoon formation, TB, chronic diarrhea, long-standing history, remitting remission course, extraintestinal manifestations, or perianal disease suggests Crohn's disease. Now, serological evaluation, a lot of emphasis has been done on this. So it has overall a limited role. There is no false positive MAN2 may be there because of previous BCG vaccination or a non-tubercular mycobacterial infection. The IGRA and tubercular skin tests are non-specific for GITB and can be positive in both conditions. So diagnostic tests for TB, definite are culture, AFB, stain, caseating granuloma. All of you know better than us what we know. Supportive can be granuloma, IGRA, or a skin test, but serology has no significance. So presently, the available serological tests are extremely non-specific and can be done away with to diagnose GITB. Coming to serological evaluation of Crohn's disease, ASCA, ANCA markers, they are not helpful. Not sufficient evidence to support them. So in a nutshell, can be avoided. So we come to endoscopic features. This is a colonoscopic image. 4 images are there. Number 1 is on the left side, that's the cecum. Number 2 is a cecum and ascending colon. Multiple aphthous ulcers are there. On the D picture, you have ulcerations and pseudopolyps. Ulcerations and pseudopolyp-like lesions in the cecum. You can see small protrusions that are pseudopolyps. On the 4th image, you can see a gaping IC valve and distorted cecum. So this diagnosis is TB. Coming to Crohn's, you see the image B. The first image is showing ileum. You have multiple small aphthous ulcers. In the second C image, you have deep serpiginous ulcers with pseudopolyps. The D image shows cobblestoning and F showed longitudinal ulcers. So distinct features on colonoscopy to differentiate between TB and Crohn's. These features are of Crohn's disease. Based on just colonoscopic findings, 4 features typical of TB and 4 features typical of Crohn's were given. For TB, -1 point was given for each feature. For Crohn's, +1 point was given. This is just to simplify the diagnosis when you are stuck with clinical features. So a score of 0 or less was suggestive of TB. A score of more than 0 was suggestive of Crohn's disease. So that is how important the colonoscopy findings are to differentiate these diseases. This is the same thing put in a chart form. So in a nutshell, look at patulous IC valve, circumferential or transverse ulcers, it favors tuberculosis. Multiple small aphthous ulcers, longitudinal ulcers, skip areas and cobblestoning favors Crohn's disease. Coming to radiological investigations, we hardly do enteroclysis nowadays, but to diagnose this, again, it's very, very important. With enteroclysis image, you can have Fisher signs, Sterling signs, purse string signs. You can show yellow, that's a shrunken cecum that is pulled up. There's Sterling sign in the blue dot that is there. But most of them, it's not very commonly used. So I'll skip to other commonly used tests done. All these features are of TB. For Crohn's disease, you will have pseudosaculations, aphthous ulcers, and cobblestoning. Now, ultrasound is coming in a big way to differentiate TB and Crohn's and to follow these patients of IBD. In ultrasound, we can easily see the bowel wall thickness. We can look at the lymph nodes and ascites, omental and peritoneal thickening. You can have these thickening and you can take biopsies also. So ultrasound does help, a simple tool to diagnose GI-TB. For Crohn's, if you are able to measure the bowel wall thickness, it's usually more than 3 mm. If you do color Doppler, active disease is hypervascular. You can see a lot of vascularity in that. Vascularity can be small to continuous vascularity, depends upon how severe the disease is. You can have hyperechogenicity in for mesenteric fat and can have regional small lymph nodes present. Coming to the important diagnostic tool that is most commonly used by all of us, that is the CT scan. In active Crohn's, active TB, you will have circumferential wall thickness, mucosal enhancement because of inflammation, but there will not be any mural stratification. I'll show the image of mural stratification later. Look out for extraintestinal manifestations for TB. Look for necrotic lymph nodes, ascites, omental or peritoneal thickening. If we have a cocoon formation, the small bowel is within the cocoon, or if you have involvement of other solid organs like liver or spleen, all these do favor TB. For Crohn's, the thickness is asymmetrical. Then you'll have mural stratification and mucosal enhancement. Here we'll have typically Coombs signs because of inflammation. I'll just show the image. Fibrofatty proliferation and mesenteric fat stranding, mainly because of inflammation. As we'll see the images. So you see the loops with ileal thickening on the first image. The mural stratification is something like a target sign. The various walls of the intestine are thickened separately, forming almost similar to a target sign, that is called mural stratification, typical of IBD Crohn's. And then you have a Coombs sign. It's almost like a comb with fibrofatty proliferation. You see the Coombs particles coming down in the third image. So these are more common for Crohn's. Here you see ileocecal thickening with the necrotic lymph node. And again, an MRE picture of ileocecal thickening. So necrotic lymph node favors tuberculosis. So again, CT really helps to differentiate the two things. Lymph node with necrosis, highly accurate for TB. Coombs sign and skip lesions, multiple parts of GI involved, highly specific for Crohn's disease. So based on these, predictive markers have been given. How long is the length of intestine involved? Do we have Coombs sign? More than 3 segment involved, it is Crohn's. You have short segment involved, less than 3 centimeter. You have IC junction involvement, it's probably tuberculosis. Again, a very important study that came out from AIIMS looked at the visceral fat by subcutaneous fat ratio. This is done at L4 segment of the L4 vertebra. And if the visceral fat by subcutaneous fat is more than 0.6 with long segment involvement, the specificity for diagnosing Crohn's was 100%. So very, very important diagnostic tool, simple tool. One CT image you can see, look at the visceral fat by subcutaneous fat ratio and look at the length of involvement. Do we be very sure about this is Crohn's or not Crohn's? So based on this, again, Dr. Kedia from AIIMS has given a flow chart. If you have necrotic lymph nodes, it is tuberculosis. If you don't have necrotic lymph nodes, you have the visceral and subcutaneous fat more than 0.63 with long segment, it is Crohn's, no doubt. If you don't have any of these, it is probably TB. In between, you have to do the detailed workup. So CT, look for short or long segment involvement, valve stratification, symmetrical or asymmetrical thickening, Coombs sign and fibrofatty proliferation. You'll come to a reasonable surety of what the disease is like. Again, MRI is again showing inflammatory stricture. You look at the white dense picture showing inflammation, in T2 weighted image of MRI. Histology, we look at the architecture and the inflammation, where the crypts are distorted, crypts are branching, crypts are shortening, or do we have multiple inflammatory markers, lymphoproliferative infiltrates or granuloma? It's basically 2 things that we look at in histology. If you have caseating necrosis, granuloma, and macrophage-lined ulcers, this is TB. Just to look at various histological pictures, you have epithelial granuloma on the left, picture A, and acid-fast bacilli supports tubercular diagnosis. You have skip areas in between with microgranuloma, small-sized granuloma without caseation. It's Crohn's disease. All coming to other specific tests for TB like PCR, Gene Expert, Multiplex PCR, TrueNat. They have good specificity to rule out TB, but sensitivity is low. So coming to the gold standard for TB, culture, histological demonstration of AFB, caseating granuloma, and other histological evidence as just mentioned are gold standard. For Crohn's, there is no such gold standard. So we have to combine all these tests to come to the diagnosis of Crohn's. Even after these tests, we are confused. Then we have to look at response to ATT. That is the Logan's criteria. The sensitivity of gold standard for tuberculosis test is low, and we don't have any gold standard for Crohn's disease. So what is the role of empirical ATT in these patients? Once we give empirical ATT, how do we know that this is TB or not? So anybody? We look at the clinical response, or we look at the mucosal healing, or we look at both. Any idea? Residents? Anybody? So gold standard for this is looking at the mucosal healing. You look at the blue chart, blue line up, patient who had mucosal healing at 2 months, all of them had TB. In Crohn's disease, only 5% had mucosal healing. So if you have mucosal healing, potentially it is tuberculosis more than Crohn's disease. And the clinical picture also improved in 40% in Crohn's. So you can't really say that Crohn's patients treated on ATT will not have clinical improvement. How to follow if you don't want to do a repeat colonoscopy? Fecal calprotectin is a simple test that can be done at 2 months. It has a very good sensitivity and specificity and good ROC curve to differentiate healing and differentiate TB versus Crohn's. In TB, you will get the response. In Crohn's, you will not get the response. Multiple papers do suggest the same thing, that fecal calprotectin and to some extent CRP may help differentiate the two cases. If the patient is not responding to ATT, but you were sure that patient had TB, probably it is an MDR TB than a Crohn's disease. So this is in a nutshell the whole diagram. Look at the clinical presentation, look at imaging, CT findings, colonoscopy findings, if possible histopathology. This will help differentiate TB from Crohn's. If you are stuck in between, ATT trial becomes the way to move forwards. If you start ATT, look at clinical response and mucosal healing at 2 to 3 months. If you get that picture or fecal calprotectin has come down, it is probably TB. Otherwise, it is Crohn's disease. Review the diagnosis. Guidelines also suggest the same. Look at the response, clinical response, and resolution of symptoms at 2 months to say TB versus Crohn's. Now, for all high-tech doctors, mobile-savvy doctors, a mobile app has been developed by All India Institute of Medical Sciences. They have taken retrospective patients of Crohn's and TB, more than 650 patients of Crohn's and 400 of TB. They have finalized the best performing algorithm. They have put it in form of an app. This is the app developed by AIIMS New Delhi. It helps you differentiate between TB and Crohn's. This is how the app works. The app is called Crohn's AID. Open the app, accept, move forwards. There is a prerequisite list that you will have to select. Move forwards, enter your details, go and enter the patient details and all the features, and you will get the outcome. It is TB or Crohn's. A very useful day-to-day kit if there is a doubt that it is TB or Crohn's. This app is called Crohn's Aid. It is available on Google Play. Anybody can easily download it. A day-to-day surrogate helper to diagnose and differentiate between the two. So with this app, again, paper published by AIMS, they found it to have a very good sensitivity and specificity to diagnose TB with a very good positive and negative predictive value. So AI is the savior, or we are just still a step behind? So this is a summary slide of the potential difference between Crohn's and TB. You have fever, weight loss, shorter history in TB, ileocecal lesions in TB, caseating granuloma, large lymph nodes, necrotic lymph nodes in TB. Rest of the features suggest Crohn's disease. So I am one step forward or one step back. Potentially with AI, we have taken one step ahead, but still 10 to 30% of patients, we do end up giving ATT before we diagnose Crohn's disease. Thank you. We're happy to take questions on this.
All branches are open for questions.
Okay.
If there
We
are
are
any
open for Q&A.
questions, all branches open.
Hello.
So, all branches are open for Q&A.
Sir, can I have a question?
Anyone from Lucknow first? GPC Meerut, you have any Q&A? Anything? Any questions? GPC Meerut? Okay, so we can move to GPC Banaras. Banaras, any question? You can reply on yes or no. Okay, GPC Gorakhpur, you have any questions? GPC Gorakhpur, yeah. Please unmute yourself. Yeah.
Tuberculosis patient includes immunocompromised or immunocompetent, especially patients on biologics and HIV. Is there a difference in the clinical manifestation of abdominal tuberculosis among PLHIV or on patients on biologics versus otherwise immunocompetent?
Okay, GPC Gorakhpur, you can write the question in chat box.
Please put your question in the chat box.
GPC Gorakhpur, please in chat box. So we can move to GPC Kanpur. Any question?
Are you getting the voice?
GPC Kanpur, any question?
Yeah.
Yeah, please go ahead.
Yes. Thank you for the excellent talk. Sometimes we start ATT when you are in a dilemma in the diagnosis. And after giving the ATT for 1 or 2 months, there is only partial resolution of the ulcerations and all these things. So should we continue the ATT or we have to revise our diagnosis?
Yeah, so as shown by AIMS study, 40% of patients with Crohn's disease would improve on ATT. They will have symptomatic improvement. Mucosal may not be there. So it's very empirical to reevaluate at 2 months of ATT. If the patient's clinical symptoms have improved and mucosal healing has happened. Mucosal healing is much better. All patients with mucosal healing have TB. 5% only of patients of Crohn's would have mucosal healing. So if mucosal healing has not happened, fecal calprotectin has not come down, there is partial improvement, only partial improvement in symptoms, then potentially it is Crohn's disease. And at 2 months, you need to revise the diagnosis.
Sir, there is a question from GPC Ayodhya. What is the common cause of very high eosinophilia without bronchial asthma?
That is probably not for me.
Okay. Does the patient of abdominal TB included HIV and biologics? From GPC Gorakhpur.
That the patients of abdominal TB and include HIV and biologics. I don't know what they want to meet. Biologics, how to give? So suppose the question is actually now TB is coming on Crohn's. There is a patient of Crohn's disease who is not getting ideally controlled. We want to switch to anti-TNF therapy, suppose. Now the issue is, does he have latent TB? You do the markers of latent TB and you find that 1 or 2 markers of TB, latent TB are positive. Then you first have to give 2-drug ATT at least for 1 month before you initiate anti-TNF, and you will have to continue at least for 2 more months. Then continue anti-TNF.
There is one more question from GPC Gorakhpur. CD among HIV, any difference in clinical manifestation?
CD among HIV, any difference in clinical manifestations? If CD, basically, if the CD4 count is good, again, CD versus TB, you will have to go through the whole algorithm to differentiate between the two. There is no specific marker of HIV that comes into play. The issue is CD4 count has to be high. If CD4 counts are low, the probability of infective etiology is much higher. So potentially it might be TB. You'll have to do further workup.
Then there is a question from GPC Meerut. Empirical therapy for suspected TB patients, whether to stop at 90 days or complete up to at least 6 months.
Yeah, so we discussed this previous questions. At the end of 2 months, you will have to reevaluate. Look at the mucosal healing, fecal calprotectin, clinical symptoms. Mucosal healing has happened, clinical symptoms have improved, FCP has come down, potentially it is TB, continue that.
From
I think if there are no further questions, we can
there is a question
conclude
from
the session.
there is a question from Agra. What is your standard initial treatment in CD? What is your standard initial treatment for CD?
Standard treatment for CD depends upon the severity of disease. Is it a stricturing disease? Do we have a fistula? How severe the disease is? If all these issues is long segment, multifocal, stricturing, fistulizing disease, you may require anti-TNF early. It is a top-down therapy. If it is a mild to moderate disease, there is something known as a CDI score. It is between 150 to 220. You may start with steroids with azathioprine and then see the response. So it depends upon the severity of disease, fistulizing, stricturing. Multiple factors have to be taken into consideration.
Thank you. Thank you, sir.
Dr. Gaurav, for an excellent session.
Thank you.
Conclude the session now.
So we are
and
closed
conclude
for all the
entire
Q&A now.
program. Over to the organizers now. Thank you.
Thank you so much, sir. So requesting the speakers and chairpersons to move to the felicitation area. So by this, we come to the end of this gastropulmonary conclave and hope all of us have gathered much of the knowledge, be it asthma, COPD, tuberculosis, or Crohn's disease, or any inflammatory bowel disease. So I thank all the August gathering here for their active participation and the branches which are online with us. And my heartfelt gratitude to the speakers of today. Finally, I request Professor S.C. Chaudhary, sir, to please deliver the vote of thanks.
So thank you, Dr. Amboj. Good evening to everyone present here and all those who have joined this gastropulmonary conclave online from different cities. Before I give my formal vote of thanks, there are two good news for all of us. First one is, at the recently concluded EPICON 2025 at Kolkata, Dr. Sanjay Tandon, Chairman API UP Chapter and Chairman API Lucknow Branch, awarded the Most Distinguished Member Award for the year 2024. For this, I request Dr. Suryakant sir and Dr. Gauradas Chaudhary sir to felicitate Dr. Tandon for this achievement. Secondly, API Lucknow branch was awarded the best city branch all over the world, all over the India. And for this, I request to felicitate Dr. Sanjay Tandon. I request Dr. Atul Mehrotra and Dr. Rajiv Avasthi to felicitate Dr. Sanjay Tandon, Chairman, Lucknow branch, and Dr. Nirupam Prakash, Secretary, API Lucknow branch.
allow me a few words? Uh, I feel overwhelmed to acknowledge the appreciation I have got today. And actually, this doesn't belong to me. This is by the efforts of, this is with the efforts and the conception of Dr. Kausar Usman, who to perhaps bring this Lucknow API to the limelight. They were the instrumental in launching or perhaps the inception of Lucknow API. So the credit goes to them. And we were furthermore guided by our teachers, Dr. C.G. Agarwal sir, Dr. Manoj Kumar Mitra, Dr. Ahuja, Dr. Ashok Chandra and Dr. Jeevan Prakash in carrying out this good work. This academic accomplishment is also because of their resolve. Furthermore, I would say that without a good executive committee support, trophy not only to the executive members but also to each and every member of the society of Lucknow API. And I just want to bring this out of its cover before you all. This is dedicated to each and every member of API Lucknow branch. So it's because of your cooperation, your confidence in us, and your participation in each of our seminar or CME, whatever we have been conducting for the past few days. This belongs to you all. So I would request each and every member of Lucknow API to just come in front after Dr. Shyam Chand Chaudhary proposes a vote of thanks. Then we can have a group pick of all the members of Lucknow API. And I would request you all to stay back for that.
I'm thankful to all of you. These two awards, in fact, are testament to your dedication, love, and respect for Lucknow branch of API and for the UP chapter. I'm thankful to all of you. In fact, this journey started way back when Professor Kausar Usman, during his tenure, it was his idea to form Lucknow branch of API. And then with the active support of our teachers, all the members, especially the past founding chairman, Dr. Atul Mehrotra, then Dr. Rajiv Asti, and my secretary, the dynamic, vibrant Dr. Nirpan Prakash, who has been working with me in tandem for the betterment of API. And I think all of you are responsible for what we have achieved till date. Thank you all, and let us keep this flame alive and fire burning. Thank you.
Now it is the time for the felicitation of our organizing committee. For this, I request Dr. K.K. Savlani to felicitate our organizing committee members. Dr. Sanjay Kumar, Dr. Saten Sonkar, Dr. Dinesh Kumar,
A big round of applause for all of them, please.
Dr. Ambuj Yadav,
Keep the applause, please.
Dr. Deepak Bhagchandani, Dr. Rajiv Verma, and Dr. Vijay Kumar. और कुछ बोलो।
And now I'll finally
नहीं मेरे बाद
I'll request both the chairmen, Dr. Atul Mehta and Dr. Rajiv Awasthi, to please stay. I'll request to felicitate our dynamic and versatile UP chapter secretary, Dr. Shyam Chaudhary, for all his efforts for bringing this program today live.
So, dear friends, on behalf of API UP chapter and API Lucknow branch, first and foremost, I would like to thank our esteemed speakers, Dr. Arjun Khanna, Dr. Gauradas Chaudhary, Dr. Deepak Talwar, Dr. Gaurav Pandey, for sharing their valuable insights and expertise with us. All the lectures were truly enlightening and thought-provoking, and I am sure that we all leave here today with a deeper understanding. Thank you all for taking the time to be with us. I also thank all the chairpersons from all the cities for taking out time from their busy schedule and gracing the occasion. Further, I would like to extend my gratitude towards our teachers, Dr. C.J. Agrawal, Dr. Jeevan Prakash, EC member of API UP chapter, and all city branches of UP API for their guidance and support. I am thankful to our satellite branches of UP API for joining and making so interactive and successful program. I am also thankful to dedicated members of UP API and all city branches and my dear students for making this academic program successful. Further, I would like to extend my heartfelt thanks to our organizing committee for their dedication, hard work, and meticulous planning in making this event successful. A big thank to you, to everyone who worked behind the scene for the flawless conduction of this event. Last but not least, I would like to thank Mr. Rajiv and his team from Sun Pharma, our academic partner of this program, for their generous support from the initial conceptualization to the final execution of this event. Dear friends, we will have 9th endocrinology update on 29th March. Please save the date. Once again, thank you all for your contribution to this academic meeting. We look forward to future collaboration and knowledge sharing opportunities. Now I invite Mr. Bikram Pal Mehta from Sun Pharma to extend vote of thanks.
The residents are requested that they should move to the left side of for their for meeting with their drinks, and the faculty and the senior members to the right. Thank you. Yes.
Hello, thank you so much. I'm Vikram Mandirta on behalf of Sun Pharma. Really thankful for UP chapter, API UP chapter, and Lucknow chapter to be a good prominent faculties and the audience presence in the program and the coordinators in the different locations to make this program successful. This is the first kind of hybrid meeting. We'll continue to have this meeting further and invite you for the dinner and cocktails. Thank you so much.